Yên không? Cảm ơn thầy.
Good morning, everybody. Let me in. Let that was one. Okay. Have a wonderful day. Be good at school, okay? Go. Sada, hurry up. It's okay. Go put on your shoes. Sada, walk him nicely. Sure. How's everybody doing? Good?
Great.
Okay. लेकर वो ये दरवाजा बंद. You can wear the blue shoes. Run. Blue or black, wear whatever you want to wear. Okay. So today we would be doing this chapter, exercise and activity, and we'll go back on discussing the key points. That okay? Share screen. दादा जरा इसको हेल्प कर जानी. Okay. Oh shoot, the screen. Is it now we can see, right? Okay. So just give me one. It's only up and up again. Take all the laces out and everything you do, the frog will not get up. You stop doing this. Look, they will not get up. Why are you wearing it? Wearing them. इसको कौन सा फ्लैट इसको चाहिए क्या फ्लैट इससे ज्यादा क्या खुलेगी It's getting late for school. You want to go to school? Put your shoes on now. Flap and flap, flap to flap. Doctor? Hurry up. This is Jumala. Put in the clothes. Okay. So the activity that the chapter we are doing is exercise and activity. For today, it says exercise and activity. Being active is important for physical and mental well-being. That is very true. If you are physically fit, you can be mentally fit. If we do have any physical issues, it just brings down stress for us, our clients. If they are not physically fit, because they're older adults, it brings them stress, it brings them mental issues. Illness, surgery, injury, pain, and aging can cause weakness and some activity limits. That is very true. If a person is sick, a person has gone under any surgery, is injured, has pain, and aging, definitely it causes weakness. People have limits; they cannot do the same amount of exercise, lifting, and stuff. But when our clients, when our residents, they are in the residential homes, they are in the long-term homes, we still promote activities. We still do some rehab exercises with them. We just tell them, okay, this is the time for your activities. You all will pass this ball. So making them move from their place. Okay, now one step up, one step down, your left foot up, your left foot back down, kind of mini Tai Chi moments we ask them to do so that they can stay healthy. Inactivity, whether mild or severe, affects all body systems and mental well-being. That is true. Anybody who is not active, whether he is mildly or severely inactive, will have a lot of effect on our body. That's why our clients who are total care, who are very not all of them are sick, but have very limited activity, means they cannot move in the bed, they are at a risk of skin breakdowns, they're at risk of other mental issues. Support workers can sustain injuries while assisting clients with exercises, activity. Make sure you practice proper body mechanics. Again, you guys are helping them. You can be at a risk of a lot of injuries if you do not really help yourself by using proper body mechanics. If you and if we think we can pick up a load of 100 kgs and we are only capable of picking up 10 kgs, it is also going to affect us. Always, before we start, warm up exercise, starting with people, moving our arms around, stretching ourselves before we start up with our clients would be the best scenario to start on. Exercise and activity. Health team members provide exercise and activity in all clients to an extent possible. Deconditioning is the loss of muscle size, strength, and function, which is called muscle atrophy, that results from immobility and inactivity. If a person, suppose, had an ankle surgery, had any surgery, and now is not moving, is not using the affected leg, what happens is this muscle, it becomes short. The thing is, the fibers of the muscles becomes very stiff. If you don't use those muscles, they no more become elastic. Elasticity keeps them long. If you do not use them, they lose that elasticity. It becomes short of size, because you can know, if you see the rubber, you pull it, it goes back, right? And it becomes the right strength. But if there's a rubber which is already not working, either it will be pulled out and it will not go back to its place. That time here, that rubber becomes long, but this muscle, it becomes small, short, just because of muscle atrophy, and that will again cause troubles, complete inactivity of that patient. To help promote exercise and activity, you need to understand bed rest, how to prevent complications from bed rest, and how to help clients exercise. Let's say our people who are in bed, what do we do with them? They can never do exercise? No, that's not right. We do also do exercises with them. They are called range of motion exercises. When they are lying in the bed, they can move their arms like this, arm open, left arm open, right arm open, arm closed, flap your hands, then wiggle your toes. Those are called range of motion exercise. Move, twist your wrist, another one, twist your ankle. Those are called range of motion exercises. There are a lot of motion range ROM, range of motion exercises. We have a list. You can always perform those with them. Generally, bed rest in order to reduce physical activity, reduce pain, encourage rest, regain strength, and promote healing. It's only that part when it says about this, that this part is only concerned when a person is he has had a surgery. Other than that, people who are already lying in the bed and they say or have fractures, we say bed rest for them. But who are lying in the bed as a vegetative or a couch potato, you don't say this is just because to reduce pain or encourage rest, regain strength. They can never regain strength. Once you lose strength, you can never get back the same amount of strength in your elderly clients because they are declining. Every day they decline. Even for us, what we can do last year cannot do this year. Same thing with our clients. They are older adults. They are very weak. Their strength is not same. Their immune system is not same. If they decline, if they get into a surgery, if that person was able to walk off his own or off her own, it might not be the same. She might need a cane walker or any assistance. These types of bed rest are common in strict bed rest. Everything is done for the client. Bed rest with commode privileges, yes. Some people, they are lying in the bed and they can still be able to transfer their said self from bed to commode. Again, we are talking about these people who are quadriplegic, who are paraplegic, who had a surgery. So those people can move themselves. You put a bedside commode, again, the bedside commode, they can transfer. We will help them to transfer them to the side and then back to bed. Bed rest with commode privileges, some ADLS are permitted. When we say bed rest, people at bed rest, one is complete bed rest where you don't move at all, which is if somebody has fracture in his spinal cord, then we don't. That's called a different fracture, spinal fracture. People with spinal fracture, you might be doing complete bed rest. But if it's not a spinal fracture, you might ask them to move on the commode, then go back. If it's a fracture in the somewhere in one of the vertebrae or dislocation in one of the vertebrae, as ribs are fractured, you might ask them, you are in the bed rest, but they still can move, reposition, go to the bed. But if it's spinal fracture, no. Bed rest with bathroom privileges. Clients can use the bathroom for elimination needs, written as bed rest with BRP. So those clients who are who have on their care plan BRP, that means they can, even though they are at the bed rest, they can use commode at bedside because they cannot poo. There are a lot of people who can poo when they have a brief on or when you give them a bed pad. They can do that. Complications of bed rest and immobility includes pressure ulcers, very, very common. And once you put someone and you do not reposition them more than 3 hours, you would see pressure ulcers start to get developed. Constipation and fecal impaction. When you put people in bed, they will start to have complication. When you move, when you start to move and you start to ambulate, your bowels start to work. They start, you can get a poo-poo. If you do not move and you're always sitting in a bed, it's very hard because your bowels don't move. They don't get enough circulation while you're sitting. You cannot go to the washroom. You cannot have a bowel movement. It's very less you can get. That's why you have to do a fecal immersion. Either you have to give enema, you have to give suppository. It will be a big work. And if the person hasn't gone for a couple of days and has been eating, then it will be too much trouble. So it's always better to move them from bed to chair and from chair to bed, at least. Urinary tract infections and renal calculi, they can get kidney stones, blood clots. People, if you do not move, you're always in one place, you are at a risk for blood clots. Those people who are lying in one position, they do not move their body at all. And you would say, if they're at a risk of blood clot, what do? We give them blood thinners. So that every day we give them at 5 o'clock blood thinner injections so that their blood keeps on flowing to all the organs. Otherwise, if you're sitting, you would see if you sit in for a while, you will feel a cramp coming in. Sometimes we feel a cramp in our arms, in our leg. This person who's lying forever in the bed, what would happen? Imagine. So there is no blood flow. That is the reason we give them, and then they're elderly, so we give them blood thinners so that every day the blood thinner stays there. It stays in their body, it gets accumulated and it works for them. And when we give blood thinners, the most important thing that we do is we do not give everybody gets the same amount of blood thinners. No, we weigh them. After weighing, we calculate the amount of blood thinner that they will get. Pneumonia, people who are at in bed rest who do not move are at a risk of pneumonia. This is not just the pneumonia that you would say is because of cough. This pneumonia is called aspiration pneumonia. When people are lying at the back and they drink, they eat, so while they eat and drink, portion of it slowly starts to grow because our esophagus and our airways both are very close to each other. They start a little bit goes in, little bit goes in, and it keeps on accumulating in our lung, ending up the same way we have water, we have cough during pneumonia. This is called aspiration pneumonia. So they are at a risk of aspiration pneumonia. Contractures, again, if you don't move, if you stay in one position for more than a month, your muscle, it will get atrophy, it will become small. You will not be able to regain that strength back. Orthostatic hypotension, it means when your patient is in bed and he's at a bed rest, we do not simply start to go with them. We ask them, you will need a postural vitals or you will do orthostatic hypotension. That means when they are lying and then they suddenly start to get up, they get dizzy, that's orthostatic hypotension. The blood suddenly after a very long time has to go to the legs, which is abnormal, which will bring dizziness in them. For these kind of people who are at bed rest, we would tell them, hey, would you mind doing a orthostatic vitals? First, your client is lying, take a vital, then sit him up, take a vital, and then stand, take a vital. Syncope, that means dizziness and anything that gets into a blackout of dizziness and you don't know for just a small period of time, like few seconds, you don't know anything what happened. Oh, I just got, you know what, I don't remember what happened. It was so black, dark, and then I don't, this is syncope. Good support care prevents complications from bed rest, promote good alignment, yes, assist the range of motion exercises, ensure frequent position changes at least every 2 hours. These are part of your care plan. These things will be always written in your patient's care plan. Supportive devices are often used. Bed boards prevent mattress from sagging. You will see under the bed. Footboards prevent plantar flexion. There are footboards and we move them when I always tell you that move the feet up, elevate the feet. There is a footboard and some, if it's a new bed, it will work on a button. If it's an old one, then you will have kind of a wheel and you rotate the wheel. It keeps on going up. Trochanter rolls, they are like round, what is it called? Towels. We always use them under, hair, legs, knees. We use those. Hand rolls are hand grips. They are a trapezius steel triangle. This is hanging on the patient's mid abdomen, and we ask them, okay, this is your range of motion exercise. What you do, put your hand up, you hold their hand, they will put it on there. Now hold on to it. Move your arm like this, move your arm like that. Hand rolls or hand grips prevent contractures from thumb, fingers, and wrists. Splints keep the elbow, wrists, thumbs, fingers, ankles, and knees in normal position. We have splints, we always use them. Bed cradles keep the weight of the top linen off the feet and toes. See, this is a very old bed. We no longer have these kinds of bed, but the only thing we have is a plain. This is no longer like a rod. It's straight. If ever the new one would have button, the old one straight with one handle only. Trochanter roll, and then they start to, you put this in, ask them to rub, ask them to fold, push on it, squeeze on it. Okay, can you just squeeze on it now? Open, squeeze. This is how you do range of motion exercise. See? Exercise helps prevent contractures, muscle atrophies, and other complications of bed rest, which is the pressure ulcers. Some exercises occurs with ADLS, when you do the ADLS, when turning and moving up in bed without help. Those who, if you don't assist someone, if you do not use sling, if you do not pull them with this pad, you don't pull them up and down. They can, okay, squish your bum up, and they like this caterpillar pull themselves up in the bed. That would be that is considered to be one kind of exercise that they are doing. A trapeze is used. That's a triangle steel rod for exercise to strengthen arm muscles for clients to move up and down in bed. So that one is used when you ask them to hang on it and do their arm and leg exercises. And also sometimes we ask them to hold on it, and then with that move yourself up. Can you please hang on it? Now push with your legs and keep moving. So that helps them, gives them strength, and that's also a way of doing exercise for them. Range of motion exercises, ROM, involves moving the joints to the extent possible without causing pain. So what we do is these exercises are done to the extent we keep on going 20 minutes, 30 minutes, till the time when we feel that they don't feel pain. Active range of motion exercises are done by the clients. And when passive range of motion exercise, someone moves the client's joint. If they are not able to, we hold it and we move them for them. It's just that they can move of their own. They have the right side weakness. So what we do, we hold their arm and then we move it for them. This is passive. When active assistant range of motion exists, with active range of motion exercises, the client does the exercise with some help. Same verbal help. Ambulation. Ambulation is very important. If you do not move out of your bed yourself, eat and sit on the bed or on your couch, you will not be able to have a BM. You won't get a poo-poo. But if you eat and you walk here and there, you will right away be able to go. One thing. The second thing is ambulation is important to be independent. Third, ambulation is important for all your muscles so that your muscles get strengthened. We have to pay attention who we are ambulating. Again, what this person is gonna use for ambulation. Is this gonna be a cane? Is this gonna be one two-wheel walker? Is it just gonna be standby assist where you only put a belt around and they will walk, but just in case they might fall, we'll hold them with this belt. So would it be a wheelchair or it would be a power scooter? What it would look like. After bed rest, activity involves increases slowly and in steps. So when you have a person who is in the bed rest, you would say, now you would be sitting, today you're going to sit up in a chair for a while. So he or she will sit up in the chair for 15 minutes. Then you would sit up in the chair for how it starts. You would be sitting up in chair for 3 times: breakfast, lunch, dinner. Okay, he or she can get it. Now let's walk to the washroom. They tell you how to move, which aid to use. You walk him up to the washroom, quite a few steps. When this starts, okay, let's walk in the hallway. So this is how you start up with them. And if you're walking, sometimes you also use a chair for a backup. What if they fall? They will fall just sitting on the chair. So one person is holding them and moving them step by step, step by step. The other person, that's how physio does it. When physio is trying to see how the patient can move, they are again at a risk of fall, and if they fall, they are going to break their bones. So again, we can't afford it. So how they do the physio, there are 2 people or 3 people. One will give them an aid saying two-wheel walker. If they see, oh, she's not able to drag it, or he is able to drag, or she's able to drag, they will give them a 4-wheel walker, whatever. And the backup always is the other person is keep on pushing the chair just nearby the feet. What if they fall? Dumb. They will fall sitting on the chair, so they don't get hurt. And when we talk about this ambulation, another thing that we also have to make sure, when your patient is in the bed, he's at a bed rest, or he, let's say, not complete bed rest, but has been moving, has pain, what do you think we should do before we move them, before we start doing exercise for them? The person is having arthritis. He or she, yes, in fact, she needs to do exercise. But how? How can she do it? She's always in a terrible pain. And how can PT and OT come and assess her? So our job is to advocate. Hey, when we move her, she's always in a pain, or we need to move. You will go to your nurse and say, we need to clean your patient, we need to reposition. But she has horrible, horrible back pain. There are people who have so many back injuries, they cannot turn on right or left because of pain. What do you do? Does it mean we never change them? No. You always give them pain medication half an hour prior. So that means if you plan to, let's say, change them at 9:30, you go in, you request the nurse, hi, are you looking after bed 1? Yes. Would you mind giving her some pain medication? We will be changing her, or we'll be moving her, ambulating. That's when you do, and how you advocate and how you help. Walk regularly, help to prevent deconditioning. When you walk or your client walks every day, few steps, not mandatory to walk like a long walk in the hallway, couple of steps from the bed up to the door, that would prevent muscle loss, it will promote strength, it will promote the functioning, and it will not cause more loss of function for them. People who are overweight subject their joints to increased weight, which can contribute to osteoarthritis. If you are obese and you're very big, pediatric, you are putting too much weight on your joints. You are overusing your joints, and when you overuse your joints, it causes osteoarthritis. Obesity and a sedentary lifestyle are the main contributors of OA. If you see a patient, if you see a client, anybody who is suffering from osteoarthritis, they would be. The first cause is they are too big, they are obese, and the second thing is they have lack of activity. They do not move their body quite enough. That's why they get this OA. When a client is falling, now, suppose your client is falling, what do you do? What is your job when your client is falling? The support worker's instinct is to try them to prevent the fall. Okay, we'll buy it, but we'll not buy the whole thing. Means if your client is falling, you don't go and hold them, you don't run, and you just can direct them. You're gonna fall, we see. It depends on what kind of fall. We always might prevent that. If this person is falling or has fallen down, we will hold his head so that we prevent head injuries. But we don't do anymore. Maybe the slides 2022, I don't know, we don't do it. You could injure yourself. However, trying to prevent a fall could cause greater harm. You could injure yourself and the client as you twist and strain to stop the fall. That's why you might injure yourself. We don't know. We'll just let them to fall. If the client is falling and you are there, you might put your leg in, they might slide so that they don't hit their head. But we do not hold and we don't sprain our backs. No. If a client starts to fall, ease the client to the floor. See, if your client is falling, you don't run and hold and pick them up. You ease them to slide. Means you are just standing there and he's now falling. You can prevent, you can sprain your back, but you can put your leg slightly there in a way that he might slide on your leg so that he doesn't or she doesn't hit her head. But you don't prevent the fall by holding and spraining your back. No. Walking aids. Walking aids support the body. The types of walking aid order depends on client's condition. Again, the amount of support needed, how much, and the type of disability the client has. Again, when they are using some walking aids, make sure you remind them to put the brakes on and to put the brakes off. When they are going to stand up, would you please put your brakes on now? Yes. Now when we are going to move, brakes off. You're going to sit up on the commode to turn around. Would you put the brakes on now again? Because if it's moving, the walker is moving, they will not be able to stabilize themselves. So sitting and getting up, that time, the walkers should be locked. And then when they have to move, it should be unlocked. Crutches, very important. Most of the people do not know how to use what's the proper way of using a crutch. If you do not use if you don't use the crutches properly, again, it can cause muscle atrophy, it can cause pressure ulcers. Crutches are used when the client cannot use one leg or when one or the both legs need to get and gain strength. Follow these safety measures. Turn the crutch tip. It has a tip at the bottom. You have to turn it. Check the crutches for the flaws. Yes. Tighten all bolts. It has a number of bolts. You tighten them. Those are to make the length small, make the length big. All those bolts. Make sure the client wears the street shoes with flat non-skid socks. Yes. Soles. Make sure the client clothes fit well. Practice safety rules to prevent falls and keep crutches within the client's reach. What you do is when you are using a crutch, you do not put them in your elbows. You lean on them. Your hands, when you put it on them, when you put there, you put your strength on them. You do not put them under here and then walk. That's a wrong way to walk. I've seen most of the people using crutches is wrong. Cane. This is a cane with a four wheel, and this is a four stoppers, and this is and the other one, the picture we have next is a cane with one. See, this is four stoppers. Mostly some people might use this. If a person is very, very independent, then they will use the first one. If the person is independent but not really stable, then we use a four stopper one. A cane is used to help support a side of a body that is unsteady or weak. It helps promote balance and support. Single tip or four tip canes are common. A cane is held on the non-affected side of the body. The side where it's non-affected, you keep it on that side. Some people, they're very good at using one tip, and some they use four tip, four stopper one. Walking aids, walkers. A walker is a 4-point walking aid. It gives more support than a cane. There are many kinds of walkers. Baskets, pouches, and trays can attach to the walkers. Yes, when all this is talking about these baskets, pouches, and trays, they are for four-wheel walkers. They do have. Then you have a bag. You open the bag. You put their stuff in there, and then you close. Sometimes they might not use it while you're walking on it. It has a tray. You can ask your client to sit on it because it has a rubber around like this that holds their back, and you can walk them down. This is a two-wheel walker. Again, this is walker. This one is a four-wheel walker. See, this one has basket, but this is a very old one. Nowadays, it's completely closed and it has from the front a rubber. Oh, only two? My God. Anyways, that's fine. Braces, very, very important. Again, braces are used to support any body part. Sometimes our shoulders, sometimes our wrists, sometimes our knee joints, ankles, and legs. They are used to support or align affected body parts, also prevent or correct deformities, or prevent joint movement. You will see some clients, they do not use braces during the day, but just to prevent deformity, they have osteoarthritis, they have rheumatoid arthritis. The order for the doctor would be put the braces on at night, put the shoe on the night. So what we do is just that during the night time, they might not remember, like nobody is so aware what I'm doing during the night. My eyes are closed. How do I know? I'm not even thinking. So how can I keep my foot straight? How can I keep my arm or finger straight? So we always use braces at night for such kind of people. That is also one case scenario. A brace is applied over the ankle, knee, or back. An ankle foot orthosis is placed in the shoe. Yes, it's kind of an insole. You need to keep client's skin and bony points under braces clean and dry. You report redness. You make sure that there's one finger, like the skin and the brace is one finger apart from each other, so that the entry and circulation would be good. Report redness or any signs of breakdown. If you see a blister, where the redness, you see it's kind of a small scarring, you always report complications of pain or discomfort. Again, when you see somebody has braces, let's say the braces are on the wrist, you make sure the fingers, you press these fingers, they don't feel pain. The fingers, the CWMS is good. That is color is pink, like the normal color right now. See, warmth, W is warmth. M, can you move your finger? Oh, and S, CWMS. And when you pinch, can you feel me? So sensation. This, any area where you put a brace, any area where you put these kind of supporting aids, you make sure the CWMS is there. So the color is normal. It's not blue. It's not kind of blue cyanosed. That means if it's blue, it's cyanosed. There's no, the blood is not flowing. Sometimes put a rubber band here for 2 minutes or something tight. You would see your tip will become blue. Have you seen it? Just because it becomes blue, the blood does not flow to it. Same thing if there is a brace on the wrist, if it's on the thumb, if it's anywhere here, you make sure you check the capillary refill. If you look at your fingers, you would see they're pink, and you press them, it will come back to pink back again. Yes, it becomes white, but less than 3 seconds. Sorry. So that is how we check the CWMS, and you can check the CWMS all the time. The care plan will tell you when to remove it and when to put it's always in the care plan whether the brace needs to be removed and when it needs to be applied. This is one of the kinds of braces. Not all the time we have this. See, this is another one. This one that they are using is for mostly when there is fracture and you have to put fiberglass. This one is done. Oh, hold on. Let's see what we have. We'll do rehab now. Rehab. Then we'll talk over the okay. Says rehab and restorative care. When we talk about rehab, what do we think of? Rehab and restorative care may be necessary after acute injury or illness or as a part of treatment for chronic illness or disability. When a person has a surgery, when a person gets into any accidents, trauma, any acute injury or any illness, we ask them, a part of treatment is going for rehab, going back on rehab. Rehab is they do different kinds of physical and mental, both kinds of exercises for them, so that these people might be able to regain their lost but not only physically loss but mentally also. If however some people have mental disabilities, again they go for rehab. They do psychologically they help them. They get some of the sessions. Those sessions, they promote mental well-being, is a way of counseling. They do a counseling for them. If it's the rehab restorative care, they will go for physiotherapies, warm compressions, just to promote that activity, that lost sensation. Rehab refers to a broad range of interventions that addresses the client's medical care needs, therapeutic needs, and psychosocial needs. Again, rehab does not only means that it's used physically, but it is more of an emotional help that they have. Some people, they're on drugs, they're on rehab now. In the rehab, they help them at the same time get up, wean them off the drugs by giving them small amounts, slowly, then decreasing the amount every day. That's psychological help. That's again medical care need. So rehab is very important. Rehabilitative care, the process of restoring a person at the highest level of functioning. They aim to slow down the decline function, supporting clients, maintaining function or to function at a higher capability. If it's an older adult, I don't I don't say they would gain. Think of this one. I am old, 80 years old. My eye, I can't see correctly from my eyes. But now I see, just because I have diabetes, I have hypertension, and I'm more than 80 years old. I'm a, I'm at the risk of kind of being uh, blind just because I might not be able to see. I have glaucoma. The doctor would suggest, why don't you go for a surgery? Yes, we will remove this cataract, we will remove this glaucoma, we will remove this high amount of loops that are causing trouble in your vision. We'll put a new lens. Does it mean I can see 10 out of 10? No, never. Yes, if it's a young one, then you would. But at the age of 90, 85, you put a new lens. Can I see a 10 out of 10? That's not possible. Be genuine. Yes, we are promoting. That's why when we are doing a surgery, when we are performing any procedure, we also look back on. Some people get mad. Oh, you know what? I went to the hospital, things and da, 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 da. We saw after that, we saw a private doctor and we went for a specialist, but the specialist did nothing. How will a specialist do anything? Because he's looking at the outcome. The outcome is you are more than 85 years of age. You are more than 75. What is the outcome if I do this thing on you? Some people, they are 91 and they have some heart troubles. They want them to get open heart surgery. What will the open heart surgery do? Why don't we put a stent in, which will help them? Why don't we put a pacemaker? Instead, doing an open heart surgery, removing the blocks, can this person survive? Okay, this person will survive, but how will it work? Like, he's 91. So those things with age, with terminal illness, if some people are at 90, they still do that. Depends if they don't have diabetes, depends if they don't have any hypertension, they don't have any cholesterol. How many of them don't have those? Very few. 1 out of 100. So that's why when we say we are giving these rehab cares, we also have to look on what and who is getting it. Is there a chance that this is going to help? If we do an open heart surgery on this 91-year-old, what benefit will it give? Look at the bright side. Oh no, we want it. You want, the family wants it, but we don't want to do it because it will be a cost for us, healthcare. Then another thing, how will it help? She still has those underlying causes, and it cannot be, it can go at this point. But if it's young, there always would be the candidate to go for all these things. So we always look who is our right candidate for any of the rehab purpose when or surgeries or any other procedure. We can't put everybody there. Yes, come in, you have this, let's go. No. Client's goal may include returning to work. As I mentioned, not all of them are above 75. Some of them, they're still working, they're young, they might be in their late 40s, 30s, 50s, like that. Resuming ADLS, they have to perform as they were doing before. There is a person who is a forklifter. He uses these lifts to pick up huge boxes, or the cements are working in the construction working, and then they use those lifts. Something happened. He just got injured. We do a surgery, and he needs to get back to his normal work function. This kind of a person goes to rehab every day. We make sure for this that rehab works in a way where it's 100 out of 100 for them. Means they should be working just the way they were working before. Usually provided by nurses, physiotherapists, and support workers. They will come and tell you, hey, it might be a nurse, it might be a physiotherapist, or it might be you. So they ask you, would you mind doing this range of way? Open up legs, they give you instructions, you have instructions, they show you one time what to do, and then you are the ones who do it every day with them. Restoring care, it's aimed at prevents health deterioration and maintains or improving clients' life and quality of life, but also aimed at restoring clients to their previous functioning levels whenever possible. We can only always say restoring back to the previous function if possible, not possible in all ones. Usually involves client and family, nurses and support workers. When we say they should regain their strength back as before, or they should regain their strength back again, we are kind of referring to getting help not only from a client's family, it can be nurses, it can be support workers. Hey, we are doing all this thing here. Now he's good to go home, but you know what? You need to do everyday exercise with them at home. So you'll be the one doing it for them. Other professionals may be consulted as necessary. Or there will be someone who will come to your home every day at this time. You might be going to Burnaby Hospital, or let's say you will be going to this care center every day for getting this physiotherapy thing. Goals of rehab and restorative care. Care is based on client's condition, how the client is, what is the condition of your client, young, old, older adult, or completely, uh, we can say, in their late 85s. Specific goal is to reduce reliance. Yes, why we want to do? We want to make sure that we promote independence. We do not want them to be dependent on anyone anymore, or for very minimum help. To improve functional abilities, to learn new skills, to prevent further disability and illness. Rehab takes longer for older clients. If it is an older client over and above 65, it takes a very long time, almost forever. For clients who are too weak to perform ADLS, restorative care may be used to promote self-care. Oh, when you're lying in the bed like this, put your neck up. Okay. Elimination for peeing and pooing, for positioning, sitting up, mobility, moving from one place, and like from bed to chair, from chair to bathroom, like that. Communication. Some people, not only we can say these need help in moving. Some people had a TIA, they had a stroke. Um, now they like it's severe. Just 2 days or 3 days ago, they had a stroke, massive stroke, and they cannot speak properly. When they speak now, they stammer. I'm going with because this is happening because the muscles of the face, the cheek, and mouth, they have lost their ability because of this stroke, this CVA, this TIA. What we do is we do a rehab with them, we restore and try our best to get their speech back. Speech therapy. Cognitive function, they lose. Yes, you are my nurse. Okay, where are you? you are my nurse. I am your nurse. Where do nurses work mostly? They don't. I'm in the shopping mall. Okay. So we help them. We tell them, no, you are here. Try to redirect over and over again. That's increasing their cognitive function. Prevention of unnecessary decline in functioning. If people go on rehab, if they feel like they're going in dementia, they're declining, there's something going on which we can prevent, we put them back on rehab. Emphasis on whole person, that is their illness and also their disability. Let's say we treated this person's left side weakness, but what if we don't treat the hypertension? This person might get this issue again just because his blood pressure is not controlled. So we also emphasize on illness. We don't say we can remove it by, uh, but we can always put it under control. And when you put it under control, the effect on the patient's activity would be getting better. It will get promoted. Restorative care must focus on the whole person, physical health, as I mentioned, emotional and social health. Yes, they should be emotionally strong. Oh, it's okay if now you are on a Foley, it's okay. Same thing, social health. They feel like they're cut off now, they cannot wear beautiful dress, or they might go to the people's house, it might stink. So it does also affect their life socially. Intellectual health, and some people, I would say, when they get into any accident, when they get into any trouble, seriously, they lose faith. We and in rehab also not only do one job promoting activities, also work on their faith. If somebody is a Muslim, somebody is a Christian, somebody is a Buddhist, Jewish, we try promoting it for that. Rehab settings, again, hospitals. It can be a hospital. Most of the time it's hospitals. Cardiac and respiratory rehab. I told you, if a person has a heart attack, if a person has any issues with pneumonia, AKI, all those things, that time, progress for complex medical and surgical conditions, use of robotics and virtual reality. Somebody who got a scope done has ulcers, they put a camera through, rehab needs to work. Someone who's on GI bleed, he has upper GI bleed. Now losing blood, we do a rehab. After they are lying in the bed for a long time, we help them. Someone who had fractures, contracture fractures, had weights hanging on their bed just because to put the feet proper, and they were very huge weight, and now they got this fat, they got rid of this fat by surgery. We again same help them with this rehab. Specialized facilities, they focus on specific problems, mental health disorders, substance abuse or addictions. There are rehabs where people go who have low score on the mini mental, like the mini mental is, what is your name? My name is this. Okay, do you know where you are? Yes. What is the day to day? What is the last thing that you have done? We do, it's a scale, it has these things in it. Can you spell car? And they would say car. Now, can you go back? Can you tell me the spelling? CAR. Now, from back to the front, if they are able to say RAC, then you write on that paper how many words did they miss. That's how we do this for them, mini mental. And based on that, we help them. We give them small amount of drug, then go reduce. That's how people go there. Some people who are not able to kind of pay attention, they lose their focus every time. They are all over the place. They go in rehab just to gain their focus. just to work on their ways of getting focused. Long-term care facility, they provide similar care like in hospitals, community care, home care services, and adult programs. They come in, they're dropped off so that they learn how to do it. Just like school daycare, we have adult daycare. They've been dropped off at 10 and the family comes by at any time in the evening and takes them on. Just because they cannot do well, they don't do well when strangers come in their home. So they have been put in for different strangers at different points. Home's assessment identifies safety risk, health hazards in the client's home. Let me give you an example. A patient had a fall at home. Now she's going home and rehab is going to help them, saying, how did you fall? What was the time when you fell down? What was around and how you had? So they go in, they look into the client's house. Oh, is the washroom appropriate? Yes. Does it have a handle inside? No. Okay. There's a commode? Yes. Does that commode also has a side handle to hold on? No. They put that thing. They install those things that are needed. She fell from a bed. Which kind of bed is it? Is there a handle? No. So they put it on the wall. Those are the things that rehab does. They do also when we say home assessment. Is there a because he or she might get tired while taking a shower. Is there a shower seat? No. Okay. She's living in the ground floor or first floor. She has a room, but she quite often needs to go down to the kitchen, which is in the basement. Can she walk the stairs? How many stairs? 10. Can she walk? No, she had a fall before. How to reduce fall? Electric rail. They get installed. So these are the rehab plans, rehab things that we do for them. We install those things for them just to make and identify that this say the patient is safe, the risk of having a fall is minimal. You may assist in completing assessment. You may go and say, yes, while I was giving a shower, there's nothing to hold on for the client. Okay, side rails for the washroom, shower rails for the washroom. So that's how, oh, when I was sitting her on a commode, she has to get up. The commode, it doesn't have side rails or there's nothing for her to hold on. So she's unsteady. When you're being sent for home care, you report it, the rehab will come, the occupational therapist. In rehab, mostly occupational therapists work, physiotherapists work. The occupational therapist is the one who install all these, not the physiotherapist. So they come and install those side rails, that electric, what is it called, lift for them, so that they're if they are in the first floor, they need to go down on the ground floor, or they are in the ground floor, they need to go up in the bedroom on the first floor. They install that just to sit on it and it takes them up. And you report all your concerns to your supervisor, whatever you see in their home. There is, the patient may wander, the patient might have trouble with keys, she might forget, oh, why don't we get them a lockbox? Lockbox is the numbers, and you always tell them only press this key and that, and they will put the instruction next to the lockbox. Rehab team, the client is the key team member. This is true when you are doing a rehab, when you're working with a rehab team. The first and foremost thing is, if your client is not able to help, you might not get any help. You might not be able to help your client, because rehab is for those people who want to be back in their independent state, who will be able to perform their activities of daily living again. It's not that a person is bed rest and he has rehab. No. What can If he's not moving forever, what can you do? Turning, range of motion is decided, but you cannot think of sending that client. He's not an appropriate candidate for rehab. Families provide support and encouragement. Often they help with care when the client returns home. That's true. Some families not only returning to home, they also help you at your hospitals. They also help you at your rehab centers. They also help you at your facilities. There are clients who go every week on the weekends to their home, live with their daughter, live with their son, get back on Monday. That's a routine for them. Okay. Every part of your job focuses on promoting clients' independence. Whatever you are doing, whatever setting you're working in, you as a support worker, your job is to promote independence. Your job is to help them with getting independent, with not depending on someone. At the same time, safety and confidentiality, do not forget. What is the role of a family? Family support is critical role in rehab. I'll give you an example. There are clients who come to us and let's say they are addicted, had went to a party, drank so much alcohol, and it happens every day. We send them for rehab just to get their mental state back. They help them with the rehab. But when it comes to rehab, if the family is not contributing, it will not happen. When they have to go back, who is the person who will come and pick them up? The family doesn't help. Okay. In rehab, we were treating them, oh, you're important, your life is important, your loved ones love you. We do a counseling. But what kind of counseling is that? When it's the time for them to go, they don't know. The family doesn't accept them. They don't come and do it for them. They don't come and take them home. These kind of people go back on it. But the one you drank that night when you were drunk and were brought to the hospital or brought to the rehab center is the one waiting for you outside. The drugs, people who are on drugs, they do also have families, and their families know, oh, he's on drug, he might sell. They don't allow them to come in. Now they were with an overdose, they came to hospital. We treated them, or they had been sent to psych ward. They've been treated there, gets their rehab program. Family doesn't accept. The same druggy friend who helped her or who helped him to get onto these drugs stands there waiting to take him or to take her home. And the mother, or this is real scenarios. I'm not telling you. If you work in rehab, it's so heartbreaking. Some of them have a habit of stealing, right, for drugs. And we do rehab programs. We try to help them. Then when everything is done, we expect the family will come. Family says we don't still want to come. We don't want a relationship with them. The old friend with whom he stole and who got him these drugs or got him into drugs is standing outside. Think about what your mind would do. Would you reject him or would you accept? That's why they go back and back, back and back, back and back on drugs. Just because they don't have that family support. Nobody wants to. They think, I myself might be judgmental. I might not think of they can get better, they will not use any drugs. They might not stay. So counseling family members plays very important role when it comes to counseling, when it comes to rehab. If that's not there, the support is not there, the rehab will not work longer. The effect of the rehabilitation will be zero, just because they will, after a week, they will go and they will do more than that, because they know how does it affect now. Because during the time they were in rehab, they got to know how many times my family called for my status. How am I doing? When I got discharged from the rehab center, who came for me? Oh, it's my friend John. That is when it really, really, really throws them into drugs, into substance abuse, into all these things, more than what they were doing. Okay? Families need to learn about illness or disability and how to care for the individual. Family members may need to learn new skills. Counseling is provided as needed to help the family cope with many changes affecting them. Yes, sometimes the kids, they have anger issues. We're walking, hit someone, became a police case. When they ask them about, they just say weird things and stuff like that. We recognize he needs to go for rehab. And when that thing is done, again, family needs to know it has happened, yes, but he or she has stopped doing this. It might be a good chance for them to support them mentally and physically. Okay. Therapy and training. The rehab team chooses the therapy and training needed to meet the client's goal. Equipments are also ordered. Prosthesis if the person has lost a leg, lost a foot. Somebody who got into an accident lost a foot, arm, or something. We use a prosthetic leg. We try to put them in the rehab, walk with them every day, every day, every day, slowly till the point they learn and accept this prosthetic leg, prosthetic arm, whole orthotic apparatus worn to support alignment, prevents organs muscular. This is what we say like prosthetic leg. This one orthotic could be boots, right foot boot. That could be one of the things. Again, when you talk about these prosthetic things, fully colostomy, those are also had a cancer, went for a rehab for a long time in the rehab because they lost their hair, they lost their um, moving abilities in hospital. They take them to rehab, and then if it is a colon cancer, they no more can eat too much, or their part of intestines has been removed with surgery. They will have a colostomy bag. The rehab will work on it. It will make them mentally prepared that you will be using you will be using a colostomy bag. Colostomy bag, the colostomy should look red, not really red, pinkish red. It should not be beefy red. This wound will heal up. When this will heal up slowly, slowly, you cut the colostomy base. They teach them, they teach you, but you won't be at their place every day. Okay, that's why they teach them, they try to make them learn how this works, how you will empty your leg bag, how will you change it to your leg bag from a night bag or from a day bag or from your regular Foley bag. Those are all the things how equipments are being met to help people's need. Eating or drinking devices, NGs, we can say not only NGs, but uh, also IVs, self-care devices, self-care device. These sensors, diabetic sensors. Every day you don't have to poke them. They go, use a phone, that one. Devices to aid mobility, again, cane, walkers, blah, blah, blah. Other equipments for ventilation, CPAP, BiPAP masks, CPAP masks. I can't sleep at night. I snore. My husband snores. Blah blah blah. They go on rehab. They help them with their oxygen level. They make them go on these CPAP humidifiers, BiPAP humidifiers, all that. And then you will be the one going in. You would say, "Hey, what is my job?" You go put it on the face. Make sure there's enough water. And when you say you don't add normal water, you add NS in it. You go grab the NS, make sure it's there, the right amount is there. Assisting with rehabilitation and restoring care, support workers are vital for giving assistance. You play a very important role in the client's progress when the client is frustrated, when the client is slow, and when the client is not accepting that I need to work on this one. This is a part and parcel of my life. The person is diabetic, he got amputated below the knee. There is no knee, under the knee, no leg, half of the leg and foot is gone. That time, it's your job to console them, let them already, the rehab is working with them, how to put this prosthetic lower leg. It will be like that. Support workers must be patient. You have to be very, very patient with them. You have to be very supportive. You have to be empathetic. You have to think, if I am this person, what would it look like? What would I need? What is the scenario I'll be looking forward for? Listen to your client, may be able to pass on vital information to the therapist. I don't know how to do it. I'm not ready with this ileostomy. I'm not ready with this colostomy. I just want to pull it. So those things, you might pass it to the therapist so that they can work on their mental well-being, telling them the importance of what is going on and how important this equipment that is being installed in their body is important. Practice dips, yes. You tell them it doesn't matter, you have a Foley leg bag, it's not gonna affect your dignity. You can always, if you don't want to carry the big Foley bag hanging on your walker, you might use a small leg bag. And your pants will be on it. It's dignity. So you as a person, give them that information, support them, try to tell them all these things to provide and promote their dignity, their independence, their privacy. For clients, during this rehab and restorative care, they might be the ones who are at a risk or are declining in their function, who needs to maintain or improve their functioning, who needs to restore clients, prevent functioning whenever it's possible and to what level it is possible. Preserve the client's quality of life and independence. Somebody who can now, instead of using a ceiling lift, or because he had a surgery, was being on ceiling, and now you're doing a rehab, they're able to use a cane. So they don't need much of your help. You promoted his quality of life. He's good with what he is being now using. And at the same time, the dependence is gone. He is independent. He can do things of his own. He might only need minor help from you just to get directions. For Canadians, shorter or no need for hospital stays, re-employment programs, rehab programs for individuals who don't have a need, who do not need acute care. There are people who don't need acute care. Acute care means they don't need to be in the hospital. They're medically fit. Everything is fine. It's just that they cannot move their arm. Can we put them in a hospital? No. They go to rehab center. In the rehab center, they are being worked up under the workshops of CBA, stroke, TIAs, where they help promoting giving them medications, giving them blood thinners, working on their weak arm, working on their weak leg, or the function that they have lost, maybe speech function. Cost saving, yes. Think about this. If you need to go to a person's room, person's home every single day, help them, still and you need to be going 4 times a day. Home health will send you 4 times. Some people get 6 times, 8 times, 3 days in a row, 5 days in a row. How would it look like? Will it be cost saving? No. Why don't we work on this rehab? We know he's a young adult. He's just in his 50s, late 50s. He had a stroke. He can get back to the function. This is this. And now let's talk about our previous slides. Now, when we talk about this, how do you think and why do you think it is very important that you need to know about all these things? We talked about mobility, we talked about rehab. I know, but how it is important for you to also know that. We talked so much about clients. What do you think elsewhere we need to know? What else do we need to know about this?
Like we have to know the situation of the patient so that we can handle it without any problem.
What if, what if you were working, suppose you were working with your clients, you hurt your back. Is this piece of information important? Is this rehab important for you? Always think about this when we are because we are dealing with clients. We are always at a risk. We are always at a risk and we are exposed to a vulnerable area where we ourselves can get in a situation where we need to get rehab. Oh, trust me, you work 5 days a row. Won't you get burnout? I need to get some rehab room. So it is not only for you, for clients, it is also for us. Sometimes it's us who needs this rehab. Rehab because my back hurts, I've been lifting all day. I need the rehab. I need the rehab just because to know the situation. I have been
couldn't hear you. You're really breaking up.
Okay. So we need to know this rehab thing just because our client, I work in psych. It's also sometimes our families might get into trouble and we need to know about all these functions.
We'll also end up one day over there.
Oh yeah, we all will mostly end up there one day. Slowly and steady things go.
Yeah, it's better like to know how things work, so that's
Yes.
why we know. But it's our scope of work, so we need
But
to know about it.
when the time comes when we have to go in the rehab, I don't know whether we will be in the right sense of mind. And we know, couple of days before when I was working, I had a lady. She was so wonderful. And we expected her during the night shift to be the best patient. Unfortunately, she was on a heparin infusion just because her blood was so clotting. So we had to give warfarin, heparin. We were putting continuous blood thinners, IV thinners 24/7 for her. When now the lab came in, they drawed her blood in around middle of the night. And unfortunately, they missed it. Oh, they took less sample. It happens when you have people in the hospital. They don't do a good job. Sorry. Now, they came in. Oh, can you tell us your name again? Can you tell us your name later? Why are you here? Uh, Sorry, ma'am. The blood sample we took was not enough. She just, okay. They took again her blood. They tried to poke her this time because on this arm she had IV infusion, continuous infusion. This they poked her one, and now they're looking for another one, and it was not there. Like they couldn't find. They poked her again. Oh my God. Trust me, she got so mad. She tried to pull her clothes out. Okay, I'm now going. I was a pharmacist. I know what I am doing. I need to go home. Help! 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 Oh my goodness sake. For heaven's sake. And I do, you know what? I don't want medication. I don't want juice. We're trying to put it everywhere. Oh God. Everybody started waking up and they were so confused, patients. The day I came on Monday and I was teaching, I was halfway. I don't know what I was teaching. It was such a tiring shift. We were giving medications, injections to everyone. Everybody woke in.
You should have given her morphine.
Oh my God, you can't do anything with that. And then finally we told her, I don't want injection. Oh, it will be a bee sting. I hold her and gave it to her. She's still, and the worst thing is when they get agitated, most of the time their kidney function is very low. And the kidney function is very low, the medication doesn't work on it. It
You
stops.
can you give sedatives to a patient?
You give them, but they don't work because of the low kidney function. What happens is you give them again. You give them again. It doesn't work. And when it is their time to go home, they fall. And during the day, they will sleep. Just because you gave them so many sedatives through the night, they will sleep through the day. Now, nighttime will come, they will be awake again, awake like hell. Oh my goodness. Sometimes things you want to program them, they do not work like that. It is not all the time the same. Sometimes it works, sometimes it might not work. Some clients, when I was working at Eagle Ridge Manor, there was a guy, you giving me food? You want to kill me? He doesn't want to eat. Oh, it was such a big hell, trouble for him. For us to feed, no, it has poison. Okay, what do you want? Nothing. He goes in and starts to take food from other people's tray, which they're not kids. Everybody is dementiated there. They don't want to give it. It works. You will see a lot of troubles. You will see a lot of drama. You have to work according to the drama. You have to be very careful how things work, but at the same time, be very careful when the family is around. I told her, okay, I know you're a pharmacist. Oh, I know. I will wait. I'll call the police for you. We'll through. We'll just ask the police to take these ladies out. You keep lying there. Okay, I will wait for you. I was not. Then I came back and told her, the police is not there. They might take a little longer to come in because we had given her injections. I was waiting when this injection would work. I gave her twice. It is at sometimes not all truth works. At sometimes not all things. It's just that's why I gave you whenever we read through the slides, I give you the real truth and this book knowledge. But real truth, you should be aware. You might not get exposed to it right away, but it's better to know before. And it's better to see and be vigilant with when you're working, how your partners work. pick up your partner's points, how things can be fixed, how things can be settled, how conflicts can be settled down. Sometimes we do have conflicts with our own people we work with. That conflict is so bad when it comes to co-worker conflict. It is the worst conflict we have to undergo. We don't have to be judgmental. We don't have to get into arguments. We always have to promote dignity. We have to promote independence. We have to give privacy. You might get a phone call from like your nurses get, or you are sitting there, then suddenly someone comes in. It's a family. You don't say she was mad throughout the night. That's why we put a bell for her. I'm so. What happened? What is this? Huh? Huh? Oh yeah, it's just for safety purpose. She was trying to come out. You don't. The nurse will tell you the whole scenario. It's just that she was trying to come out of the bed for her safety. We put this lab belt. Oh, I don't want her to be in restraint. Okay, we'll try to open, but meanwhile you're here. We'll open her up, but if you don't mind letting us know when you will be gone, just to make sure that she's safe. Okay, okay. Would it be there forever? Will she not be moving? Families ask you these questions. Oh yeah, everything would be fine. You might need to talk to the nurse. You might need to talk to the doctor. So your words, you have to learn how to speak. We all know how to speak, but we have to learn how to speak in a way which will not kill. Some people, they are on active dying protocol. If you see a butterfly outside the door or outside the curtain, make sure it means the person is the one who is dying. You need to go and check on her every half an hour. Is she breathing? Does they are, because they're about to die, the rigor mortis does not hit them that time. Rigor mortis means, when people die and they become stiff, you cannot move them. Once person dies, within a couple of hours, rigor mortis will start to work. But when people are dying, they are on this active dying protocol because they're not eating. They're almost every system has stopped working. They bloody become so stiff. If their hands are like this, the hands will remain like this. You want to move the arm, hardly you can move the arm. Make sure you don't do that. You just grab some small towels, put them inside between so that it doesn't get red. If the person has passed away, your job is to get a tie till the family will come. If the mouth is open, it will stay like open. How will it look for them to look at their loved one dead in such a way? So you tie their face after it's done. Beautifying, you will have to beautify them. Once they are passed away, you open all those ties.
If their mouth is open, how do you close that?
Right away, you know what? Because air like open like this, you just push it and then put a what is it called, gauze. It's like a gauze plane. You put underneath like this is, and then tie it like a woofy butterfly. You make a butterfly clip here like Minnie and Goofy, like that, so that it will hold their mouth. And when within hours the rigor mortis will hit, it will become close.
Okay.
That's why I said working in healthcare is like a juggling job. It's not physically, it is something you also have to think critically. What needs to be done when? Who needs to get what? Where do I do this? You have a patient who got a fracture, who has weight bearing. Like they put big plates of weight bearing on their bed. Is it appropriate to move those? No, it's not appropriate. Would you be able to move them? No. You won't be. Repositioning the foot is not meant for that client. Do you get me? Not everything is meant for everyone. You have a person who has who's now, let's say, total care, cannot move the arm. We are the ones who will be lifting their arm, doing this exercise with them as range of motion. Okay, now in, out. They're not able to. I'm not able to move my arm. Now you will be doing this one for me. This is what you do. Okay, we're gonna do this exercise. Hold her arm, hold it like this. Okay, in, you are the one doing, but you have to still say in, oh, and then you push out. They feel like we are doing it. This is how you promote dignity. This is how you, and when you're doing, put a curtain. When you're doing this, you see, they do like this, and you're pushing, they're pushing back. It means they are in pain. Go back to your nurse and say, hey, I feel like she's in pain. When we were doing this, she was not very comfortable. Would you mind giving her medication, something for pain? And I will come back in 15 minutes to happen. Then you work on it. If you do something, think about it. You are in pain and somebody wants to move your painful arm. Would you like it? No, it doesn't matter. You want to promote my independence. I don't give a damn care. So everything needs to be done with steps. What should be the first step? What should I do now? How do I do it? You have a person and you see she is able to talk. When the family came in, they walked with the family to the cafeteria using a walker. Why don't? And now they want you, oh, can I get changed? Sorry? Yes, you don't say no. Okay, I'll put a brief on you, but meanwhile, if you need to go to the washroom, you need to press the call. Try to promote things. Try to speak very nicely. You don't have to be rude, but same words, same things that we want them to do, we can manipulate it in a way which would be look like, oh, I am able to. I need to use a what is it called? Urinal. Okay. And you see, you ask the nurse, what's her mobility? She is one person assist. One person assist. Can she walk? Yes. Okay. Yes, my dear. Can you sit on this wheel on this chair? And we'll go to the washroom. She wants to use the bedside commode. Okay. But you know that you can ask her to sit on the commode. Do not put a Vernacare product. Once she sits on that commode, it's like a chair with a hole, toilet hole. Same. Why don't you instead push that? See, it is very easy to push it and take it to the washroom. Lock it down on the toilet seat. That toileting in the washroom now. And you don't need to carry the poop to the Vernacare product machine where you will put it. You just make them sit on this bedside, on this commode chair, and take that commode chair along to the washroom. It's something you have to see and you have to think according to what and where you're working. What is the thing that is going on? Again, I need to mention this one. I don't know whether you see your client is incontinent, is a very heavy wetter. You use a pad, but when you use a pad, you still, if you miss, or she might not tell you, her clothes get wet. She will wet her pads. This is winter time coming in. When they're working, when they're living in a facility, how many clothes do they have? Do they have a bunch? No. They might have 2 to 3 trousers. And if she uses more than 2 trousers a day, would you have enough? No. What do you think I should do? Why don't I put inserts? The pads in the brief, why don't I put pads so that if ever the accident, and support the sides, if ever the accident happens, the pad will get wet, the clothes will not get wet. It will soak, it will give us time. Always think of things that you can do and it can promote at the same time the safety for your patients. Some people are so big that the extra large brief doesn't work. What do? Do I leave them on the soaker pad and they will pee every 2 minutes? No. You use double or triple pads, and when you put pad over pad, you put it like this, and underneath you put a pad in the other way. So you are, but at the same time, chart it down. You will have an iPad where you need to put briefing, yes, double pad applied. Just there are small comments, not extra large brief not available. Because if you put double pad applied, they might say, oh, why did you do it? It's just because of you the skin got broken. Because it was not available. Always remember, anything which is documented is done. Whatever is not documented is not done. That's the rule of Canada. You have a problem, you need to email. You have done some care, you need to write it down. Things that are reported, documented are done. Things that are not documented are not done. You cannot call them they are being done. Am I clear? Let's see. Let's go over with the overview of some things that we will be going. Time for us to answer our questions. Okay? Like yesterday. Okay. Uh-oh. Okay. Let's first see. Hold on. We did do this. We have done this one. We have done this one. Not supposed to do this one. We will do the other one. We'll go on each link. again. So long, let me see. What is more that needs to be covered? Canadian Center of Substance Use and Addiction. Did we do this one? No, right? We haven't done this one. Knowing your limits with cannabis. Help people reflect on cannabis use patterns like providing tips and strategies to encourage low risk behaviors, reduce harm. We can, this one, I don't think so. We should be telling them they should do it. We should know how to do these things of their own. We can always give them an information that smoking is not good for health, but we can tell them don't smoke. Please don't do those things. You always can say nicely, hey, do you know this is not good for health? But you can tell someone, don't smoke. You can say this is a smoke-free area just because you are in the hospital or you're in the facility, that's true. But physically, you cannot tell anyone not to do something. Don't do that thing. Government of. And you also need to know that you have to do food safe because you guys have a role of storing food, feeding people. You have to know how to store what is good food, how to store food, what you can do to prevent food from rotting. So you have to take a food safe course. We did do fast, facial drooping. We did that, and public health agency, health promotion, coronavirus. No. Nova Scotia, scope. Hold on, let's go slowly, slowly. Okay. Labor union mandate. Okay, my dear. Now, question for you guys. It says, describe the assigned and delegated task and how they may be different in various settings. Who will tell me? Who will answer this one? Who's gonna answer this? You guys can see this, right? Hello? Yes.
Yes, we can see.
Yes. Who will answer this? Beautiful question. 1.9. It says, describe signed and delegated tasks and how they may differ in different various settings. Let's say first point is delegated. What is a delegated task? What do you mean when we say a delegated task?
Yeah, it's you. What is your position? Whether you're in a residential support worker, or what you need to do, and what are your responsibilities?
Okay. And how it may differ in various settings. How would it be different in various settings?
Yeah,
Can
it may differ from patient to patient. A patient might need. He's old and slim, so he might need different kind of care. A patient might be disabled, so he need different kind of abilities. My abilities to look after him. Someone might be psychic. Someone might be needing more attention.
uh-huh.
So everywhere, like every patient may be different from the previous one. Yeah, someone might need more attention. Someone might need
Yes,
less attention.
that is
Someone's those
that is
toilet duties are
absolute
more.
that's absolutely correct. That is from patient to patient, but it's saying from various settings. What are the various settings?
Uh, for instance, if we happen to work in a hospital,
Hmm.
then we are allowed to, check pressure and everything using equipments
Okay.
and medication as well. But in home care, we are not allowed to do such things.
In home care, you give medications. In
Oh,
hospital, you take blood pressures.
blood, yeah.
In facilities, you only help what Amrit said. You will be taking care of them. You will be giving them based on each client. So again, this is quite confusing. In hospital, you might be doing transfers. You might be helping them with small things. You might be putting things where okay, where do these IVs go stocking things? Or if you're very good and you have been trained, you might take blood pressures. But when it comes to home care, you will be the ones giving care and giving medications.
Mm,
When it is a facility, you might be giving a shower, you might be feeding. If
mhm.
it's home, you're going to a client's home, you might need to cook for them, you might need to help them cleaning a little bit with the house. So that's how a delegated task and various assignments differ in various settings. Second question
The,
is
the setting means like the settings which are required by the for the patient.
no,
Like
when it says in different various settings, various setting means hospital, acute care.
Yes.
okay,
Yeah. When it says if it would say delegated task, how will it differ between your scope means between the patients.
okay,
Okay.
yeah,
That's why I am going word to word in these questions is how you would be able to answer for your interview. How would you be able to answer if you tomorrow are going to come and you, you don't no longer stay sane, right? Things change. You might be the ones teaching, you might be the ones helping, you might be the ones who will shadow people. If you are working now in that facility for more than a year, a new one will come, will tell you, hey, can you take this person with you? And he will be sharing, she will be shadowing you. So that means you're giving an overview. So you need to know each and every word, every key of this. Okay. So now the next question is describe how the role of an HCA may be different in various acute settings. Again, in acute care settings, acute care setting does not involve um, home care.
yeah. Acute care setting is the emergency rooms and
Yes, hospital,
yes,
emergency.
hospitals and emergency.
Yes, within acute care now, how it will be different. A hospital has emergency, as Amrit said. A hospital has a medical ward,
Mhm.
where again, a hospital also has a surgical ward. Do you do much in surgical ward?
No.
No. A hospital also has a maternity ward. Do you help maternity? Yes.
No, okay,
Very little. Like
yeah,
still, you still can change the mother, but not much, right?
okay.
Mhm.
Really. Do you work in maternity? No, Not really, just you might transfer. It also has a peds ward.
That
You
the
work with peds?
Platinum belongs to him.
Okay.
He's assigned to that,
Not
to
that vehicle. Yeah.
That's his own personal vehicle, but that's what he's been using to get in and out. They said he's not coming back. They just checked. They said they helped him load up his boat and everything yesterday. He's got everything out of the camp here now, so he's not coming back. But just in case he
Yeah.
does, he's not allowed in.
Okay.
So if he shows that to our two courts to tell him that you've got received instructions from SA management, that's he's not permitted in. If he caused a problem, call Steve on the SA phone or
Yeah, the supervisor. Yeah,
if we
definitely.
do it. I just got to run into PT. I'll be back. But
Yeah,
he shouldn't
that's okay.
he shouldn't be coming back.
Yeah, normally they don't, but he might. Yeah.
But you never know.
Yeah. Thank you.
Thanks, man.
Okay. Do you work in peds? Do you work with kids? Right?
Yeah.
Do you work in psych?
Yeah.
That's also a part of acute care setting. So always make sure that's what it says. How in acute care, there are different parts of acute care. There are different wards in the hospital where you work. Your scope in every ward is different. What you do here is different in what you do there. What you do upstairs in the medical ward, what you do for surgical ward, what you do for cardio. Did I tell you about compression stockings?
No.
No. People who are had surgery, because if your slide doesn't say anything, I might not have thrown a light on it. So people who are had a surgery, or you might have heard about varicose veins. You might have heard about staying in the bed forever. This slide today is telling you about patient's range of motion, patient being in the bed. How else can you promote circulation? Think about it. When we massage, does it help promoting circulation? Yes. Are we allowed to massage anybody? No. How we can do it? If a person is not at a risk, for these thrombosis and emboli, he or she is not at a risk for clots, the doctor might order these compression stockings. Compression stockings are like flaps. You have, what is your job? Your job is to measure this leg. You measure the width of the leg, you put the flap on, you put those two tubes on, one here, and you connect. There's a machine. You put those two tubes in, boom, it will now blow up, boom, it will blow down. Boom, it blows up, boom, it blows down. That's how it gives them massage. Your job is to take the width of the calf muscle. Your job is to get it from the utility store of the hospital, of the facility, wherever you work. Your job is to wipe it, make sure it's on charge. If it's not charged or it's not plugged in, it might only work for couple of hours, and then it's not working. Make sure it's at the right position as well. A person is not fiddling with it, he or she hasn't removed it. We don't provide massages, but if this person is at a risk of clots, or if this person will develop clots but is not right now having any issues, they will tell you, oh, we don't, and family doesn't want medications, we only want prevention. Prevention is health promotion. A part of health promotion is what is wrong, what has not happened or is gonna happen, we prevent it. So what we do is put those compression stockings in based on the patient's length. Not everybody's length is, it's not above knee. It's always below the knee. So you get the right size. It's not put on the thigh. It's not put anywhere else. It's not for arms. It's only from the ankle to the knee. So you measure the length, you measure the width, you go and check on the compression stocking, length between this to this, width between this to this. You go, grab the package, apply it, connect it to its programmer, ting, right leg, left leg. It will go. It goes up, inflates and deflates, inflates and deflates. That's how it gives them a massage. That's how it gives them this range of motion exercise in bed, how they exercise. So there are things that we are going to do in a different setting. This is your job, not my job. This is not family's job. This is your job. If you are positioning this patient, make sure you stop, you open it, and then you go. Because if it's all already on and you pull and push the patient, definitely this is a machine. It doesn't work properly. It might put too much pressure. It might compress, squeeze so badly. This person might get bruising, and you will be the person who will be responsible for it. Am I clear? So things have to be seen how differently I work in which different setting, how I can place my foot to get in, how I need to react so that I would be in a better position. Okay. It says contribute to the effective functioning of healthcare team. Discuss basic concept of team development and group processes. How do we promote or develop team development or group process? What do we do? How do we work within the team? Hmm?
Can you please repeat the question?
It says how we work. What is the concept? What is your basic concept of team development and group processes?
It's just the same, like whatever I do, I note it down, and when the next shift person comes in, the cross shift notes. Basically, cross shift notes are the words maybe I be using it now. So the next person who comes in the shift, he knows whether the early ones did his job, take down all the vitals and the things.
Yes.
And
So
plus, teamwork is like if my partner is not doing it, so I need to report it.
yeah,
Let all the team, whether we have 2 people, 4 people, so everybody knows what he's doing and everyone's doing.
so true. The basic concept of team development and the group process is, as he said, we need to work as a team. We need to report. We need to write it down so that it will become. We know there is continuity of care. If things will not be notified, if things would not be documented, there will be a breakdown in the chain. The chain will not be the same continuity of care. So the basic concept of developing a team or a group process is to provide continuity of care. Means that we gave a shower should be written every time when she gets a shower. We provided care, we gave medication should be given when was the last time and how much was it. It doesn't matter only with you, have to see each and every aspect. Because it's just saying team development means everyone who's in the team. If the doctor does not write for the next doctor that what he gave, will it be helpful for him? No. So everyone who works in a team needs to document what type of care and what did they do and what would be happening. Just that it will create and enhance the continuity of care. There will not be a breakdown in the chain. It will not stop at a point where would we say that it doesn't work. Because our center of attraction, our center point is our client. We need to support, dignify, promote our client. And how we can do it? We can only work when we are working with the concept of team development, and when we are working within a team, trying to make things better, keeping all things updated. When was the last time patient had a bowel movement? Oh, it was yesterday. The the concept is you wrote it when it was, the nurse can see, the doctor can write a medication, and it can prevent illness. Step by step, each step has a specific reason to be done. Each step needs to be done in a manner which will promote health benefits for your clients. If the patient has not slept and you report it, the patient has not been sleeping, he's agitated, she's agitated, the next day you report, the third day you report, then the nurse, she's documenting each and everything on behalf of you, that care staff notified patient not sleeping, agitated. Care staff reported patient hasn't, patient sleeping on and off, agitated. The next day, the doctor sees the note again. Oh, it is now becoming a pattern for her not to sleep. She needs something, some helping aid to sleep at night. Let's give her some melatonin. Let's give her some quetiapine. Let's start with some medication, mild medication. And job based on where you're working. If the nurse gives the medication, she'll tell you, hey, can you please tell me, is this working? Is she able to sleep when you're going on your night rounds? Make sure she's sleeping. Leave the door halfway open. Don't shut the door, because when you open the door, it might make a noise. You might wake the patient up. So just leave a small space there so that we can peep in to see if that client is sleeping. Your observation to the nurse, from the nurse to the doctor, from the doctor to the family. The circle continuity of care keeps on going. Okay? Outline the benefits and challenges of working in a team, including diversity within the team. What are the benefits and what are the challenges you may face?
Benefits are like you get a helping hand, like in a team. If you want, like you earlier said, you need a patient to move around. Plus, you can multitasking. And challenges are like if your teammates are not both weak,
Yes.
like they have a different background and you have a different background. So
Yeah.
you, like
Those
those
are,
might be the challenges.
yeah. And sometimes those are challenges within the team. The team is not compromised only of your team members. The team is also compromised of our client and client's families. Our client families are sometimes very difficult to handle. Though you
How
provide,
does a how does a client family become as a part of the team? Like,
okay, I will tell you how it becomes up, why it's a part of team. Say your client speaks Mandarin,
okay,
right? And this person or your client is non-verbal, has Alzheimer's, only recognizes one of the person. When you ask, he doesn't reply. He never replies to other patient, other answer. When that family member comes in, she or he opens her eyes, starts talking. Right. So that time, when you ask the client, what is she trying to tell you? Was she in pain? No, because when we are taking care of a person, we are taking care of our client. When we say team, a team is comprised of everyone who is a part of the client. But when we say interprofessional, interprofessional are only your co-workers, which includes your co-workers, nurses, occupational therapists. The difference between interprofessionals and team is team also includes the client and the client's family. Interprofessional means anyone from low level, starting from housekeeping till specialists. That's interprofessionals. Only those who are professionalists in medical care. But a team will be anyone helping. A family can be helping. A private caregiver can be a team member because she comes in, helps us with washes. Family comes in, helps us with feeding. Okay? Family comes in, helps us with feeding. So that's why when we say team members can be anybody. It can be, we do have benefits, family coming in, feeding, but at the same time, after they feed, there's so many questions. Why is this way? Why not this way? Can you put my mom this way? Can you put my dad this way? Can you do this? You know, there are benefits and there are disadvantages. We always have, we always say we have a privilege of things being done, and we also have privilege of things not being done. If client's family is feeding, at the same time, their complaint is, oh, while I'm feeding, the food is not good. When they provide care, oh, she's in pain. She might be in very less pain, but you try to exaggerate it just because you want her to get. We know we want them to be comfortable, but we cannot unless it's been timed out, or we can say scheduled by the doctor, by the hospitalist. The other name for the doctors we use is hospitalists or MDs. If it's not being scheduled by MDs at 8, 10, 12, 14, 16, whatever time, we, other than that, whenever we give something, is called PRN, as per needed. As per needed, you can give when your client asks. If your client doesn't tell you, can you give something of your own? No. Unless this is a fever which you can see. How can you see pain if this patient or this client is not even grimacing? He just stays like this all the time. What do you do? You know, some situations are very difficult. Not all situations are same. We get into situations where things become, I told you, you will have a overdose patient. He's already overdosed. He overdosed himself with drugs. Once they get into a hospital, they start yelling like hell, do not give me drugs. Oh my goodness, 3 floors can hear it. You took drugs of your own. That was not drugs, but we are helping you to come out of your manic attack. You are telling us, do not give me drugs. Those who are confused people, they want to run away when they hear these things. Oh, they give drugs here? I swear, you get into the situation, the confused people, they start to come out of their beds. This is not safe to be here. They forget where they are. People who are sleeping in their sleep, and suddenly they will hear, do not give me drugs. They wake up, huh? What happened? I'm not safe. Even though they are not confused, for a while, they just, nurse, nurse, what's happened? What happened? What's wrong? What would you like? You get into situations where things, it's okay, it's okay. There's a patient who's not feeling well, is just confused a bit. You don't say he's a drug addict. He's just confused a bit. We're trying to help him. Don't worry. Try to sleep, my dear. Do you need earplugs? Give them earplugs. And before you leave, ask a warm blanket so that you can go back to sleep. Yeah. Because she was sleeping when we put her in a bed. She created a scenario of getting warm, but now if she woke up, she might not be able to go back to sleep. But if you give a warm blanket, you provide that medium of sleep, put the light back off again, give them a call bell, they will keep it in hand. Maybe they go back to sleep again. If they wake up and they scream, other people scream, they might tell you, oh, okay, I might go to the washroom again. I might use the washroom now. Things becomes lengthy, things become small based on what situation you are stuck in. How and when we get into a situation, if you have a family member and you work in hospital, they stay overnight, isn't it our job to offer a chair? Oh my dear, do you want some blanket for yourself? Like, be human. And she's taking care. I don't have to go and change the brief, or she might help me with repositioning. Can you help? Some people are really good. If you see those are the ones who are like a danger zone, let them be out of this game. We play this bingo ourselves. Okay. The next thing is principle of collaboration, cooperation that contributes to effective team functioning. We can always, when we say collaboration and cooperation, we collaborate with other people, we help and coordinate with our same and below and higher hierarchy of people. We do provide our views and our observations, and then that becomes an effective team function. Oh, yesterday, when we were sitting in the dining, the patient was not was not able to move her right leg. Today, when we were changing the client, uh, she had difficulty moving her right arm. If you report it, let's say, oh, what happened? I don't know. And I will keep an eye. You tell your nurse. When you go in, you might change the something, it got wet. Not every day we take all their clothes out unless you're in the hospital. If it's in the facility, it has specific days, but you always give a wash, change like the upper clothes. And now she was eating, she spilled on the clothes. So we have to move. Oh, when you change the clothes, you saw a bruise here. I told you, I reported to you earlier that she was not able to move her right arm, but now when we changed her, we saw a bruise there. Is this blue? The nurse might ask you, is this bruise purple, yellow, green? Um, is it a big or a small one? So you observe and tell whether small, large, what color. The way you tell them this is purple, this is green, this is yellowish green, tells you that she hit it couple of days ago. If it's reddish red, it means it happened maybe couple of hours or yesterday. So that's how we cooperate, collaborate. Oh, I don't know. Were you working? No, I was not working last night. It's okay. I'll ask the kid who was working last night. Does she know anything about it? Now, the nurse will let the doctor know. Hey doc, just FYI, I just want to notify you that the client in this room, blah blah blah, she's having difficult time moving her arm. As per the carriage when they changed, she was in a lot of pain and has a bruise which is small and it's green in color. If the nurse is a very diligent nurse, she might go and tell you, hey, can I have a quick peek? Because if there are questions from the doctor, she would be able to answer. But if ever she is very busy and things are not in a proper way, you might, or you would say, hey, you know what? I was just changing or this client, he reported of some pain in her or his back. I just saw there's a wound, and then she might ask, the nurse will ask, oh, is there a blister? Is there, has it popped up? Is it popped? Do you think we should put a dressing on it? Does it need a dressing? So those kinds of things we collaborate. If things become worse, the family comes in, is everything okay? Yeah, yeah. Yes. And they ask you, my mom said there is a there's something, she got hurt, she's getting the doctor is going to see her. Because they're in the facility, they don't get seen by doctor every. Oh yeah, it's just that we found she was not, because this family comes once in a while. So we found that this your mom, she was not able to move her right arm nicely, and we just very effectively with efficacy, we just found out there's some bruise there. We don't know when it happened, maybe we are looking into it. So we reported it to the doctor. The family now knows. Or the patient got sick, vomited, stuff like that, and there is now a decline going on. You see, she vomited, she might not make it, she might not be able to survive, or things are going worse. You might need to, if things are going bad, you need to notify the family. And listen, whenever a family is being called, you don't say, you did not pick up, or I picked up phone. Hello? Yes, you don't start. You should go and ask, hey, is this Miss Nima? Yes. So you are the one who is whose name is on the file for your mom. Oh yes, yes, yes. Is this the right time to talk to you? I'm calling from the residential home. Let's say Hornbridge. Yes, we are just concerned about your mom. We want to let you know that through the night she was not doing fine. She had some episodes of throwing up, or she had some episodes of chest pain, and she's been seen by the doctor. Right now she's stable, but we only want to notify you in case you want to come and see her. Okay, period. That's it. Let's say this person did not pick up the phone. What do you do now? You don't say, hello, this call is for Miss Nima. Your mom is not doing well. No, you just simply say, hi, this call is for Miss Nima, and we just want to, I'm calling from Thornbridge Assistant Living. We just want to speak to you whenever you, regarding your loved one. Whenever you have time, can you please give us a call on the number 604-708-8038. Again, 604-708-30 whatever numbers. You go slow so that they can, if sometimes there are people, they're like ridiculous. You read those 100 times, you listen to that voicemail, you cannot remember, you cannot write down the number. First time you go a little bit, 604-708. The next time when you are about to, again I repeat, the number is, you go really slow. And you do not leave the message stating what the cause is. It's just because we are giving you a call from Thornbridge, and we need to speak to you regarding your mom. That's it. Patient's loved one passed away, dead. You don't leave a voicemail saying, "She passed away, can you come in?" No. "Hi, this is a call for Miss La 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 La. We are calling from this place. It's an urgent call. Would you mind giving us a call back on number ding 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 ding." Again, the number is blah 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 blah. Blah. That's it, and you hang up. You don't leave a voicemail saying she has passed away. She has this diagnosis. No. Dialogue में भी नहीं. Because someone takes charge. So this is how you deal with circumstances. And this is how we say the principle of collaboration, cooperation, and effectiveness. When it's a team, you do, oh, what's going on? Okay, you go and ask them, would you mind giving her a briefing of what has happened, how things have happened, what care needs to be given. The next thing that we are going to flash some light is, it says, describe the role and responsibilities of various members of healthcare team, including in respect to delegated tasks. Again, delegation of tasks is between a regulatory and a non-regulatory person. Means you can, let's start with this one. You had a patient in room 306. This patient got moved to hospital, this urine facility, or this patient got moved to another room or passed away. You would go and delegate the task to the housekeeping. There, your job is not housekeeping. Any other than specifically client briefing, you don't do housekeeping. So you will go ask the housekeeping, can you please clean up this room? This room means she needs to clean the closet. Because the patient moved, because the patient passed away, because the patient is not going to come back to the room, she needs to clean the closet, washroom, blah, blah, everything. Or, however, your client made a mess in the washroom, had an episode, everything became dirty. She peed on the floor, or he peed on the floor. He pooped on the floor, or she pooped on the floor. What do we do now? Do we clean it? What we do? Grab a towel, put it on this, try to wipe a little bit so that you don't, with the towel, not with your hand, just with your, maybe with your foot a bit, so that, or you put the towels on it so that when you step, you don't step on wet. Get that wet, what is it called? Board, put it there, signboard, just to make sure that this area is wet, and call housekeeping. Let them know, hey, this patient unfortunately had an accident. Would you please come and clean it up? They will come and clean it up. Your job also because your job was to go call them or ask them to clean. Another thing, you have to pay very much attention to some things which I did not come across till now with your slides. I don't know when it will show up, but this is very important to know. It should have been there on the first slide, but I did not see it. When it comes to safety, what comes to your mind when you say safety? I want to see, does anything click up? You say safety, you say illness, you say diseases. Is there something that comes to your mind for you and for your client? Not really, because you've not been working, right? Okay. When it comes to a patient in any room 1, any setting, she's COVID positive. How do you prevent this? How do you prevent things? Have you heard about breakdowns? Oh, there's a breakout in this facility, right? What do
Yeah,
you
the virus spread around the whole facility,
But
got infected.
how do you prevent it? What do you do? What is your job? This is safety. This is client. This is you. You may ask, hey nurse, if you don't, this patient now, you confirm, is she COVID positive in room 1? Yes. Would you please help me? This in the drawer has a sign saying droplet precaution. You go, stick it on the door. You don't stick on the door coronavirus. You put droplet precaution. Anything related to flus. If you see somebody has a flu, you see somebody is COVID positive. If you see somebody is having runny nose or issues with respiratory, you put droplet precaution there. It means any person going in or going out needs to, the droplet precaution thing on the sheet does say what to do. Wash your hand first, put your gown on. After putting your gown, sanitize your hands, put your gloves on, put your mask on. Period. When you go in, you would go with all these things. When you're coming out, you would drop off those dirty supplies inside at the edge of the corner of this patient's room. You do not mix his or her dirty clothes with everybody. When you come out, you throw the gloves, sanitize your hands, and right away go and wash your hand, because this was a droplet precaution. Your job, another thing, we'll go one by one with every precaution, because it's not been, we did read safety, but we haven't come across this. Maybe in other slides we might, and that time it would be even easy for us. So we said droplet. Now this is a patient in the room, and suddenly the family comes in. They just walk in, ding ding, hi, excuse me, would you mind, oh, what's that sign? Everything okay? It's okay. She just has an infection. We'll talk about it later. Would you please mind putting the gown on, your face mask, and your gloves in? And whenever you come out, just drop them off in this. Sanitize your hands. Okay. This is this. Why? Because if you don't do this, it will keep on spreading. During COVID, we had to move every other day in facilities, in every other day in hospitals, patients, because we wanted to keep all of them in one place. We wanted to keep non-sick people in one place and sick people in one place. It was so hard to keep a track on it. Sometimes your patients, again, you are working with a vulnerable group of people who might be cognitive or who might not be cognitive. When we say these patients are not cognitive, it means that they are dementiated. They might come out of the room without, no, even though you tell them 100 times, you redirect them 100 times saying you have an infection, you can't come out of the room. What do you do now? You get, and you can't lock the room completely. He might or she might fall inside. Oh my God. Again, see, scenario came up where things were not, where things become difficult. What you do, you get those day tables, breakfast table, you might put it in between somewhere in such a way it will not hurt the patient. You kind of block it in a way you can see through the patient Put the curtain on. Okay, my dear, we are here. Put a mask. Always redirect from outside. Oh, have a seat. Don't worry, we are here. You can see through. This is what. Why we put this stage table to block, so that if the confused patient is from outside cannot get in, if it's inside cannot come out. It's not all the time the person who's sick is confused. A person who's not sick, somebody else, wanderers. There's a wanderer, he or she hops in, right? They go to everybody's room. This is a patient with flu. This is a patient with uh, coronavirus. He gets into his room. So just to prevent that, a wanderer should not go in that room, or somebody in the room, if confused, should not come out of the room. You prevent to block the door halfway through so that you can see in and they can see. Again, I'm repeating, not all the time the person who is sick is confused. The person who is in the room has a flu, has a coronavirus, is with it, would listen to you and sit down in the chair, would not mind you. But there's a wanderer in the hallway in on our floor who gets into everybody's room. You might do one thing. The wanderer, oh, you know what? He's trying to get into his room all the time. Just because he has coronavirus. Why don't we put this wanderer in front of the nursing station? You go grab a jerry chair. The jerry chair is like a chair that can swing back, 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 front, front, front. It's like very beautiful chair, not this one. It goes step by step back and forth. So we sit them in a jerry chair, get a lap belt, put them and sit them up in the front. Just to prevent it. You have to find ways out. Another thing, when it comes to people who have cancers, who have gone under radiations, who have had chemotherapies, always remember they are not considered to be same as others. People going for radiations, going for chemo, or having cancers presently, or who had or any of these radiations, chemo, or medications while ago, a few weeks before, or a week ago, are kept on cytotoxic precautions. They're always on cytotoxic precautions. For them, we do not use yellow gown. We use a blue gown. A blue gown is more protective than a yellow gown. The yellow gown, sorry, the yellow gown protects us from bacteria. But this blue gown is specifically made to protect you, your client, other people from getting into this. They are not the ones who have a bacteria. They have had gone under radiations. And when they had these chemotherapies, the chemo drugs are in their blood, we do not want to directly get exposed to these unnecessarily. So that's why we put ourselves, we use the cytotoxic precautions, we use those blue gowns, we use masks, we use gloves. Otherwise, if you want to go and help your client, you can we always put a gloves on, but sometimes there are scenarios where we touch our patients directly without putting a gloves on, or whenever we are feeding, we do not, this is a rule, a mandatory rule. While feeding, you don't put gloves on. No matter what it is, you don't put gloves on. But when it comes to cytotoxic people, we make sure we do put these things. It's just not they have any bacteria, they have any bug. No, it's just that their blood, uh, they got into some drugs. They are getting chemo drugs. Those are in their blood. There, we don't want to get exposed. And how we can get exposed to feeding is different. But when you are washing them, they sweat. When you sweat, what does we with sweating, all other things also get out of our body. So that time, these drugs also minimally there is some amount that goes out of the body through sweat. When they breathe in and out, respiration, our respirations are no matter what it is, it's wet. That's why if you have a mask on and you have glasses, you will see those become blurred. It's just that it's very, very minimum amount. They pee. With the pee, some of the drug comes out. We don't want to get exposed to those drugs. We use a precaution called cytotoxic precaution. We put it outside. Anybody going in comes to know, oh, this patient is on radiation, had a, or is having radiation. We need to put that blue gown on and the gloves on before we help the patient, so that we don't get exposed to unnecessary hazardous drugs. We don't get unnecessary exposed to these things. If you are working with home support and you're the ones giving medications to your clients with such people, the medication always say hazardous drug, please use double gloves, because with double gloves there is no chance, there is zero chance of getting it into your hands. If it gets into your hand, you rub it, you apply cream, you don't wash it, you might get it. Now you have it on your hand accidentally. You never know how things go. So that's why they always say, they write under the medication, hazardous drug, use double gloves. Hazardous drug, notify if pregnant. If there are some drugs, if you are pregnant, you might not be touching them just because it is harmful for the fetus. We don't want to take chances. The next nurse can put it in a cup and hand it over to the patient. So those are called cytotoxic precaution. The difference between any other precaution and cytotoxic precaution is we use blue gown, and other precautions always we have yellow standard gowns. Every precaution that list you would see has different what's it called, precaution, what to do and what not to do. Sometimes you would see airborne plus plus, means you do not use a regular mask, you use an N95 mask. So each precaution tells you what to follow and what not to follow. This is a safety concern. And this thing is not only meant for you, it's meant for nurses, it's meant for families, it's meant for doctors who get in. Because if you got in, you got that, let's say, flu bug on you, you did not put a gown, you got into another client, you left it there. The hospitalist left it there. The client's family left it there. So this is, if again now, if this client is suppose right now having COVID, we do not share blood pressure machines, we do not share with them the commode, we do not share any of their things with anybody else. We make sure the housekeeping comes and wipes it with other agents first, and then the regular cleaning from their side. That's why this sign outside the door tells the housekeeping this is not a regular wiping. Wipe. You have to use chemicals first then you use the regular wipes to clean it. So you as a person have a responsibility. You need to know the work, the designation, the task of each member in your team. You should be aware of everybody's role and responsibilities, who is responsible for what, including your own role, including your own responsibilities. Okay. Let's talk about these, what is it called, precautions for today. And we did not take a break. Do you guys want to take a break first, or you want to go over with all these things first? Up to you. Let's take a quick half an hour break. And after this break, we'll go over with the rest of the precautions, and then we'll see. Okay. We'll come back at what time is it? It's 11. We'll take a quick break, Amrit, and half an hour break. We'll come back at 12. Then after this, we will go over, we will finish all these precautions for today, because this is very important for you and for your clients to know what is safety when it comes dealing with their illnesses. We talked about a lot of things, but we haven't spoken of these things. We'll finish it up then. We'll come back at 12. Okay. Take your time.
Okay.
Thanks. Amrit, be back and we'll start. Are we okay to
Uh,
start?
yeah, you don't need to wait for me. I have headphones, so that's okay.
No,
You can go
but then still it looks good. Uh, Everybody, we should respect. We should start it from home, right? So we should start respecting everybody's who's coming. Okay, let's talk about more. So we talked about cytotoxic precautions, people who are on radiations, on chemos, or have had ongoing chemo radiations uh, quite for a while. So, other than that, you would also come across people who have skin infections, MRSA, right? Those kind of things. Do we do have precautions saying contact precautions? Contact precautions does not tell us to put a face shield mask, but it tells us regular mask, gown, gloves. So as I mentioned, airborne plus it says it doesn't mean the specific single mask with a shield. No, it means an N95 mask. Whether you would, that's why it's important to get your face tested, mask fit test done because because of the fact that everybody's face structure changes every year or with the days on aging. Maybe last year we were fat, this year we try to lose weight. Depends on the bone and the facial structure. It's very important. If the mask is not fit properly, it might go through through those small gaps in. Make sure you fix the mask and you align it with your nose. You properly you fit it over your ears. It's been put on. And before you put when you put this, it's called donning. When you put all these things on step by step, this is called donning. When you put them off, it's called doffing. So there's a specific way how we put the things and how we take them. We don't randomly take things off and we don't randomly put things on. When it's step one, the first thing when putting things is to put a gown on. After we put a gown, we will put gloves. Once the glove is done, then we put a mask, and each step requires sanitizing. When we have to take the things off, our last thing to put on is our face shield mask, but the time when we are removing, this is the last thing to be removed. Saying, what do I mean? You also put glasses based on what facility, what precaution, what thing is going on. Goggles. So what we do is when we have to take the things off, the first thing you would do is you will remove the unclean gloves. You'll throw the unclean gloves. You'll sanitize your hands. Next, you remove your gown, sanitize your hand. The last would be your face mask shield or your goggles if you're also there. So, why is again this important? If we break this chain, then of course we are letting infection to spread on. And every time you are done giving care to anybody who is on any precautions, please and please make sure before you get into the room, you sanitize your hands. After you come out of the room, you sanitize your hands and then wash them, because sanitizing is only there to serve a specific purpose. It does not clean and wash out germs. It just that it helps it from spreading out. But to remove all those from your hands, to be safe, you need to properly hand wash. And we do hand washing. We always tell everybody, you can say hand wash your hands till you can say the happy birthday song. Happy birthday to you. Happy birthday to you. Happy birthday to you. This is when you can stop. Less than that is not okay. That's not meant to be a hand wash. And you don't do a regular wash. This way, on top of it, in your finger grooves, around your there. That's how you do it. When if you're providing care between the two hand nails like this, that's why I said most of the time we do it wrong just because we don't. They take so long to wash their nails in there. It's better to have short nails. That's really meant to be how we need to work. Anyways, leaving that apart, that the reason why I'm telling you is you if you go into anybody's room and you are not aware he or she was on precaution, you're not only putting your other client, but you yourself and your family at a risk, because you go with those bugs to your home. Make sure you wipe your work shoes, before you enter your house. Once you wipe them, make sure you wash them. You wipe your phone, you wipe your bag properly, your badge, because these are source of infection. These things we can carry home, taking infection. So these small things we have to keep an eye on. And if somebody misses out, they don't have precaution sign outside, please always request the nurse to put it out, or if not, just go grab it. It's always on the nursing desk. There's everywhere you work, there's a nursing station. In the nursing station, it would be in one of the desks, and you just pull them out, put them with a safety needle, with a tape, depend on whether it's a curtain, whether it's a door, what it is.
Do we have to, excuse me, sorry, do we have to put the PPE every time, like change it
Yes.
whenever you go to,
Oh,
no,
yeah.
no, I'm asking like you go from one patient to another patient, you have to change it? Or if the patient's sort of one kind, then you can do it
No,
at the end of the day.
honestly, normally if it's only we are going to one client, then we don't. But the real thumb of rule is to take it out for after every client. But
Okay.
if we know all of them are same, and you're not working in a hospital, you're working in a facility, they want to save money on these products because they are paying it from their pocket. So they would say, hey, you use one gown for every side, unless a patient is on precaution. Not only that, you'll have to make sure outside the door there are enough gowns, there are enough gloves, there are enough supplies that everybody can use. The family can go and use. Understand? The housekeeping who will take the garbage out of that room will be able to use. Like, think of these things, how you collaborate, what is our importance, what do we do? If ever, again, now, You're working in a hospital setting, let's suppose. You have to move this patient from one area, he's or she's going for a scan. How would you tell them this person is a contact precaution? This person is, they won't take COVID patient? No, they always ask, because COVID patient, they don't want to contaminate scanning areas. Uh, Reason other people can get it. That's why during COVID, all the surgeries were held. We don't want anybody to get into uh, any trouble because of us, and then they will sue us for millions. It's okay. We everything was stopped, but simple scan. She's on contact precaution. She has dermatitis. How would she go to? But still, this is a concern. You might get eczema. You might get that rash if you don't let them know. Always make sure getting a gown and putting it on the patient's bed when he's going on a stretcher bed is a notion the patient is on precaution. Again, I would repeat it. We don't put a paper on the patient's bed because this patient moves on to the scan or CT or X-ray or any test on a stretcher bed. So we put, once we have put the blanket on, we put that yellow gown on it, notifying, because this is a code for us to know he's on precaution. They will say, hey, what precaution is he on? Same, when the porter is going to move him, he knows he's on precaution. This is a code word for all healthcare professionals to know a gown laid on a patient bed going from one place to another place means he is on a specific precaution. Put your gloves on before you touch him. Put your gown on before you reposition. You get me what I mean to say? So those are some of the things that we always have to pay attention to. Jumping in any room without no, you see somebody, he or she is coughing. What is your moral duty? Go and ask the nurse, hey, are you aware this patient is coughing? Is he on any precautions? She might not have paid attention. This is COVID. This is RSV positive. You see things. That's why being safe, put a mask on every time you go in somebody's room, making sure you have gloves on. And I would tell you, you work or a nurse working, she knows if I am going in my client's room, he or she definitely needs help with something, some care. Why not to be safe than sorry? Why not to put a gown on before I get in? Even if that patient is soiled, my clothes will not get dirty. Could be the patient peed. We don't know. Did he touch his brief? Now he's touching the handle. I'm leaning on on her bed. Is it gonna get onto my clothes? Why not when I get in, before I get in? Why don't I use a gown? If ever I come in contact with any of the things which is not clean, which is not safe, the things would get up on the gown. I am good for anything to be. I'm good for anything. I'm safe. So always think of safety things. That's why whenever you enter in anyone's room, make sure before you enter, can I get help here? Yes, my dear. Okay, put your gown on, put your gloves on. If you think I just want this thing to be, can you hand it over to me, this book? Yes, don't put the gown on, then you can simply, but put your gloves on all the time. This is most of the times, 100 out of 99 times a savior, because we don't touch things directly. Taking out the gloves, disposing them, and sanitizing. After sanitizing, washing with proper soap and mix a bit of lotion that is on the near the washing dispenser. Mix them together, wash them, and after that, wipe your hands and apply some lotion so that your hands do not get dry too much that they are at a risk of skin breakdown and you are at a risk of getting different kinds of infections. Anybody who is on oxygen, make sure you wear a proper mask. Mostly people with oxygen, they have they do mouth breathing as well. Their mouth is always open. They're elderly, they can be sick. Why not to put a mask? COVID is so badly affected our lives that we did get paranoid at a point. We were short-staffed that it was 20:1, 40:1 nurses, like 40 people and one nurse. What would you? There was no justice for anything. The reason being what you need, where you need, and how you need. Plan your journey before you start it. Same thing, if you're going to perform care for your client, make sure you know each and every detail of your client. Importantly, who my client is. Is my client cognitive? Does he know where he is? Is he oriented times 1, 2, or 3? Are there any precautions, whether it is contact, any of these airborne, droplet, or ABB, aggressive violent behaviors? If not, what is his mobility at baseline? How does he move or she move at baseline? And what is her diet? Diet means if she asks me for water, am I able to give her any water? Does she, uh, is she on thickened? Is she on thick? Is she on regular? That's water. If I provide her with food, is she on a minced diet, dysphagic thick? Like, you need to know this before you start your journey. When you get an assignment, you have you have the names on, you have a list. If you are working in one place, that is a facility, on the day one, make sure you organize your work, which will take a little while. Get a small booklet or keep that sheet with you. The name of your clients in your residential home, in your long term, will not change. Keep that sheet in, grab 2 different color pens, write it down. Is this person on room air or on oxygen? At the side, is this person independent, one person assist, 2 person assist, total care, a feed or non-feed? Important key points should be first, all those small details, key points should be on that sheet. And every other day when you go in, before going in the client's room, you can go through this till you will memorize once you provide care. Within a week's time, you remember the routine of this person, that person, that person, that person. Oh, who's my client who has cream? Because before I go and I'll get her cream from the nursing station. Mostly in residential homes, those it's not the regular skin creams. If they have osteoarthritis, if they have arthritis, if they have any pain, backache issues, if they have pressure ulcers, if they have small wounds, you will be, I know 101% sure, I know you will be the ones doing this. The nurse would write on them, applied by, if they are doing computer charting, it will prompt, it will not let them move forward. So they write, applied by care staff. And they put your initial. Your initial would be, if your name is, my name is Ambreen, it's AL. The initial would be this. So this AL is responsible for the cream to be applied or non-applied. Now, being a task, which is, now she delegated a task to you. That is when I am saying you need to know who my clients are. If this person is like this, what I need to do. Think of, you go there, they tell you, can I have water? You gave water, she choked. Instead, if you knew before, is he on thinking, what I need coffee? When you are in a facility, if you're working in a facility, not everybody will get ensure boost. There are very few people who do not eat their food properly. They don't finish their breakfast, lunch, and dinner. They get 3 times boost. So it should be on your small chichi the day you made, who are the ones who get boost. How often do they get? And this chichi will be in your pocket, or you might have a small booklet that you will make on the day first. That's how you work in a residential home. In the hospital, you don't have to take care of those things. It would be always written. And though in the hospital, you will have to, they might tell you, oh, you got me a tray. This is not a veggie tray. This is non-veg. I'm so sorry. I will ask your nurse to order enter for this. She will be the one to enter there that she next time wants veggie trays. Every time he or she would get veggie trays, or she's allergic to pineapple, she'll put allergies to pineapple, blah, 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 whatever it is there, so that you get what you desire to get. You help your client, he or she has allergies. She told you, can I get something to eat? Okay, you get some cookies, right? These are not plain cookies. You got strawberry cookies, strawberry shortcakes from the kitchen. She's allergic to strawberries. Did you ask? You can't ask the client, but they have a wristband stating their allergies. Before you give, check your patient's allergies. They always have a wristband, if with a red tape and white in between, where we write what kind of allergies it is. It's very important to know things and small details about your client, about your resident, about your patient. If you are the one who is helping the person with the medication in home care, you should be knowing, is she taking medications crushed or uncrushed? The time these medications, remember, the time when these medications were ordered, she was doing fine. She had no episodes of choking. She had no episodes of any issues with this speech and language. So she could take them right away, one by one at one time. Let's say not all together, one at one time. But recently she was sick and some episodes happened. She cannot anymore she like swallow them. What do? Use your brain. Would you still tell her to take medications? No. You will notify your nursing supervisor. You will notify your supervisor that this person no longer can swallow medications. She is having choking episodes. Then the SLP, speech language therapist, will come, assess her, would tell what to do with them. Mostly he can get crushed medications with applesauce, or only crushed medications with thickened water, whatever you get for that patient, you will go for it. Small things save time, small things save life. If things are not being done diligently, it might put you in a trouble. For one, you have to do the procedure and things for the person quite a number of times. Secondly, it can harm the patient. Third, you can lose your job. And fourth, you can put yourself in a state where it will become a, instead of gaining, you will be losing. Think about this. You have a patient, you made him feed that. It's important as a support worker, you go once the breakfast is done, things are being removed, take these cutleries off their tables. If you left cutleries unattendedly on the table for your client just because you got busy, the other client who is dementiated comes in, picks up that cutlery, starts to do hurt himself, starts to hurt others. It's important for us not to leave things unattended, not to leave medications there. You see, your nurse has kept this medication. Most of the time, they want to make their work short. They'll say, "Hey Nima, I just left her medication there. Make sure that she has taken." You just okay, and then you change her. You forgot she said the medication is there. Make sure she takes. She did not take it. It was on the table. The other client came. He doesn't know. He is confused. He took it. Boom. If you see the medication on the table, ask your nurse, "Hey, there's something, there's some medications lying on the table. Do you know what it is? Do we have to feed them to the client?" Make sure asking will save you. Your team as well. It's not only you. It's not only you responsible. The whole team is responsible for it. You see a sign outside the door, NPO, nothing per oral, nothing by mouth. Ask your nurse, is he not still eating? Sometimes what happens, let me tell you an example. We had a lady who went for a scan, and we had to put NPO sign there. After she came back, this sign should have been removed. But the next nurse came in and she got busy. She did not pay attention to NPO. The support workers, the care staff, they did not want to bother. They were in a rush. They say, and they saw outside the door NPO. They did not take the food, went out. The morning staff came in again. It's a bit, they kept on doing. Nobody bothered to ask anybody, is he not going to eat, or is she not going? Till the 3 shifts went on, this person got so dizzy that her glucose went down. The nurse did not realize why the patient is going down. The reason was the sign outside the door. This bloody sign, when was this put on? Did anybody ask? Maybe it was left by it was the other patient who is NPO. Okay, this also happens in workplaces and hospitals. This was the sign for this patient, right? The sign is there. The patient has been moved from this bed to bed 7. The housekeeping came, they cleaned it, but she did not remove the sign outside. It's not only housekeeping job or your job. The nurse did not. The new patient who got in was there. The nurse, she got this patient at the last hour. Think about it. She got this patient at the last hour of her work, and she did not pay attention, or she was trying to finish the paperwork and all other things. She did not see what is on the uh, hanging on the curtain. It's NPO. And she kept on doing things. When she gave the report, everything okay, we have a new patient in hospital. We have a new patient in bed 7. She doesn't need anything. She's not ABB. So blah blah. She did not say there's no precautions NPO. This, I've given her all the meds. She should be settled for the night. Things happened. This nurse, she saw from outside this is breathing only. She did not go in. He hasn't taken his dinner. Nobody fed him just because that bloody sign was there. Whose mistake was it? Housekeeping, then yours, then the nurse, till somebody asked, is he not able to eat because there's a sign outside? Guys, sometimes these things are left out. People do not pull out everything. Even though there's a precaution sign, ask. Even though there is no precaution sign, before you enter into a patient, you don't know him, ask. It is very important. Asking will save your time. You don't think, how will I look in front of the person if I'm asking this question? How does it matter? Who cares? Do I? No. Okay? These are some things that you need to know about those signs. They are sometimes very, very important. Sometimes people don't pay attention to them, that how they can impact somebody's life. There's a casual support work HCA who doesn't know these clients, came in, saw NPO, she does not go in, she just walks out and gives breakfast to other people. Unnecessarily, this patient was not fed with breakfast. Or there should have been a sign, the patient is going for a scope, the nurse forgot, everybody on the floor knows, but this is just a family member, or this is just a casual care aide. She was walking, this client asked, she passed it to her. Again, now you have to reschedule. You don't know when the day would come, when she will be done. Then you have to again ask her to stay NPO for the midnight length. Meanwhile, till things will not be checked, the test will not be run, we cannot do a proper diagnosis, patient might get sick. Think of all these things. Each thing, each action we do carries a specific reason, carries a weight of how it affects us, our clients, and our team. If your team is not really a good one, if you, your nurse, your doctor, your PT, your OT, everybody who's in the team is not diligent, you will end up with trouble shifts. You will end up with long hour shifts. If everybody does their job, what is being done really like meticulously, it will not be a trouble. It will not be a burden shift. It's not that you have to change the patient. The nurse will give the everything. Some nurses do. They will give medications and then they will say, hey, can you empty the Foley? No, you can also empty the Foley. I'm so sorry. Yeah, so if you're not comfortable emptying Foley, it's okay. You can say sometimes, you know what, I'm so sorry. I'm just busy with another client there. Would you mind doing it? Ask the nurse to do herself. But you don't say do it yourself. Hey, I'm busy with a client in bed 3 right now. If it's urgent, would you mind doing it? Done. Period. Think of how you want your things to be done. That's why the art of speaking should be learned. The way of delivering, way you deliver your speech, you deliver your words will affect your client, client's family, your team, and your work. Is that okay? Be respectful. Make sure if you changed your patient, you see there's some blood, let the nurse know, hey, we changed this patient. He had a bowel moment, but we feel like there was some blood in it. He'll say, oh, I will keep an eye on it. Your job was to report her that there is some bleeding. It can be an upper GI bleed, it can be lower GI bleed, it can be hemorrhoids. If it's a man, not all the time bleedings can be of one type. So just remember, report things that are important. If your patient, he or she is always fiddling here and there, some people they try to dig into their briefs, go grab a mitten. Just like kids, we have Velcro's mittens. Put those things on to prevent infections, to prevent them touching everywhere. We don't know where they touched. Not it's only we touch things. Our clients will not. Other patients, other residents are not going to use gloves. They might touch it. They might get into infection. It might become a big breakout. So always make sure if somebody is like digging in their pants like that, get a mirror, put them on their hands. And some, they might have long nails. Do not trim nails unless it is in their care plan. There are a lot of issues. Sometimes they have fungal infections. Sometimes they are diabetic patients. You are trying to trim their nails, and suddenly, while trimming, we go deep. It touched their skin. Now it's an infection. Always they need you put. Let your nurse know, hey, you know what? This patient in room 1, she has long nails. Would you mind notifying the family? The family will come. Either they will trim the nail or they will ask the podiatrist to come, and if they don't have one, the family will say, hey, is there anyone that you guys in the facility can arrange? Yes, we do have facility um, arrangements. We will. There are, oh, you know what? I took one time a group of CHWs to facility, and they were doing absolutely fine. But one mistake they did. It was not they did, but the whole group did. The kid from the nursing home did it, not our school. And it's not this school. It was the other school. She gave a wash. This patient was supposed to get a shower. Remember this. When incidents and accidents happen, then you come across those stories. She gave a shower. She was going to get, and it was written on the care plan, give shower, but do not wet hair. Okay. She gave a shower. She put water on her hair. It was a wig. This wig cost her, I don't know how many thousands bucks. She made it. Her family got it. It was such a big issue which kept on going for weeks and weeks. Why, when we told you when the time is for shower. This is disgrace. That patient was a cancer patient. That's why she had no hair. She used to use a wig. And you don't leave the wig in the patient's room and take her all empty with the bowl head till the washroom. It's normal for her to wear it, but you don't put water on her head. Instead, they started washing her hair, thinking it's hair. And it got crumbled, the hair. She was without a wig. It's again loss of dignity, loss of respect. Oh my God. Drag it to wherever you want. Please make sure you do not. Some people, it's their own hair, but they have got this hair permed. Some old people, they get every week their perm in the residential long-term care facilities, in their these facilities, residential cares. Now she got her, and you go in, you give them a shower. Stop. Before you do that, check, is it hair wash today with a shower, or it's just a shower without hair wash, vice versa. So think of your actions, how it affects people's life and how it affects you. Am I clear? So these are some of the things that you really have to pay attention to, what and how we perform care. Think how we need to do. We did not do it in a wrong intention. We did it for a good purpose, but we spoiled the ladies' perms in the long-term care facility. It's their appointment with the hairdresser, and the hairdresser is on the ground floor. She charges them $90. It goes on their care plan. When the family comes in, they pay for it. And just because she got her perm done on Thursday, her shower day is on Friday, you put water on her actual hair, which is not a wig, not all that, but she got the perms done yesterday. Boom! You pay for the money, you pay for the haircut, you pay for everything, and you did it, and they don't want to get care from you. Just because you did, because they're older. Oh, no, I don't want to get care from her because she did this thing to me last time. She'll do it again. Think of it. It really is. When you hear those kind of stories from each other, it looks like a joke, but when it happens, it is such a big hustle and bustle. The fam, oh, you know what, my mom said, you do this, and they come in. They get it. Seriously. Sometimes they have some people, especially ladies, they get breast cancers. One of the breasts get removed or both. So they get a prosthetic breast, that silicone breast, and it is not less than $5,000. And they always tell you, can you put it in the case bag at night? One of the ladies, she had those long nails. When she was putting it in the box, she poked it. Bing! The silicone started coming out. Oh my God. Sometimes there are so bad stories that cost us so much money. It was not supposed to be wet. It was not supposed to be kept outside. It was not supposed to be at night, because when she slept, she just slept and took turns. I don't know how she it got a small tear, and now the silicone is trying to come out of it. So we have to make sure that we play a role which is very diligent when we are giving care, especially with these prosthetic breasts, wigs, dentures, hearing aids. These hearing aids are not less than $5,000. And Hmm? Hmm. when you are just dealing with these things and you give care, simple as that. You give care, you wash the client, you roll the bed sheet, and you did you pay attention to what happened while he was turning on this side and that side? Is the hearing aid on? One is in, one is off. It went into the sheet. The sheet is in the washing. Who will pay this 5,000? Family, you are the facility. Think of it. That's why people who are on people who are on these hearing aids, normally in these residential residential cares and these long term, we put a label on those. We put their chargers and the cases near the nursing station at the time of night time. You are supposed to get them and put them in there so that next time all the people's oh, everyone's is there. Dentures in their room, hearing aids near the nursing station, inside the nursing station where they keep those drawers in and everything. So safety issues are always there. Safety comes first. We have to make sure that we are giving patients respect as well. Sometimes we do things unintentionally. Our actions intentionally cause them harm. They have glasses. Those are not reading glasses. A person with 85 who's 85 years old, who is 75 years, who is 90 years old. Do you think those are reading glasses only? No, they are to see things properly. And we know that this person is using glasses. We just ask it, it's okay, so let me go take you to the washroom. We don't put the glasses on. He doesn't even know what he is touching and he's walking. Dumb, he hit. This is safety issue. When you talk about safety, think of things being safe. Do not leave scissors and knives, forks, all these things, cutleries in it's not hospital. Hospital, you have completely all the time security. Every 5 to 6 minutes, each person comes on around. We did have episodes of clients, not clients, they are called patients having knives in their bags and stuff. And when you go in, they are already there to stab you. I will tell you a scenario. We had a patient in palliative care. The nurse, she told the nurse that, oh, this is my, she had a wallet and she gave it to the nurse. I don't need it. Why? It's okay. Keep it, keep it. The nurse said, no, 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 we're not supposed to take. Okay, keep it there. She did not pay. I don't know whether it was a nurse or a carer. She did not ask too much questions or why you giving it away and stuff. So, okay. Then she had a sweater, black sweater on. It's an Eagle Ridge, it happened. She gave it to the client, the patient in the next room, same next bed. The lady asked her, why are you giving it to me? Why don't you use it yourself? Because they are very picky, thinking she might ask me that you stole it. I don't need it anymore. Oh, really? Why? Are you going somewhere? They started talking. The nurse from outside heard it. She went to tell the nurse that this patient is talking to another patient like this. Meanwhile, they were checking the file. She had already prepared everything for her journey. What she did, she knew in my bagging area, there's nothing, knives, nothing. But how can I kill myself? She had already got the tape. You know the tape? Bloody tape. She rolled her face like ding, 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 ding. She covered it. Swear, the nurse who was walking by outside, if she would not have told the nurse, they would not have got in quickly and came across that she has suicidal ideation. They ripped it off things, because we always keep a small scissor in a pocket. When you are performing care, do not put those things on the table. For heaven's sake, don't put them. You never know what your resident, client, or patient will plan. Hello. She closed all her airway. She thought this is gonna end her journey. She wrapped herself with that tape. That's why safety issue. Thinking of somebody is giving away her own used thing. Oh, my dear, you need it. Why are you giving it away? Be very, like, you don't suspect or object that, oh, it's just why do you want to give it away? Are you okay? You don't like it? Like, start with small things, and I don't know, and just simply, I don't know, this client seems to be a little this client seems to be a little weird. Let the nurse know. I don't understand. I tried asking her why she's giving away her belongings or clothes, but she did not answer well. Just keep an eye on it. The nurse will say, oh, thank you, thank you, thank you. Your job is done. If things happen, it's the nurse who's responsible, not us. Most of the time, you will come across people who have already. We had a lady who was pregnant, had not for, I think, 8 weeks. Her family was not notified. Her boyfriend, I think she tried to tell the boyfriend, and boyfriend did not acknowledge. He did not want to keep the relationship. So now, because she can't abort her child, she came to RCH emergency, and everything, she's trying to be so nice, good, blah blah, but she's going to the washroom. When she goes to washroom, she doesn't go to the washroom close by. She goes to the washroom on the other side. Shampoo, yes. Don't press the shampoos. Shampoo will come out of. So what happened is, when she walked on the other side of this, we do have people who always keep eye on each other, and especially these security staff members. They have to come and check every often. They saw her fiddling with the hand sanitizer alcohols. She wanted to take the alcohol sanitizer box inside and drink it. Just because when she will drink it, this will become an emergency. We will have to, and she's full code. She's only 21 years old. We'll have to save her. We'll have to resuscitate her. The baby will be aborted. The reason for this was not to. So if that support worker would not have paid attention to the thing, that why she's going all the way to that washroom every single time instead of going, could be one time you go, you don't know it, hi, you don't know, that's fine, but every time you are going, it means there's something. You can tell them, hey, you know what, instead of going to the washroom there's a washroom close by here. And if they still go, you need to not really suspect, but keep an eye on it, because you keep an eye can help getting out of a lot of things. I keeping an eye, the nurse keeping an eye will change lots and lots of things. Some people, they are always feeling, and if someone is on the suicidal risk and all, now the rule of thumb in hospitals, in acute care, hospital does not mean only emergency, but it means all other floors. We have one-to-one sitter. That means the care aide is there to watch, only watch her. You don't perform any care. You just do one-to-one. Stand near her bed on a chair. Sit down, please. Don't touch this. You do redirecting them every time, making sure that they are safe. If the call bell comes in and you're not the one who can help, reason, I have a certified, they are called certified people. These people are at a risk for themselves and a risk, immediate risk for others also. Bye boy. Bye bye. So make sure you pay attention to these small things which can become a big danger in life. You will see so many scenarios. It's wonderful. Welcome and come across things in life. Some people, they don't like hallways. Some people, they don't, they report it to you. Your job is to report it to the nurse. It's night time. Some of the people who are claustrophobic, they are scared of door being closed, windows being. You have to leave some the blind open, half of the blind open. It is your job because this is their home. This long-term facility is their home, right? So think of those small things, how you prevent and make things easy. How you help making this journey a safe and smooth journey. Okay. Any questions? Anybody has any questions? Nima, are you there? I don't think so. Anyways, this week I will be marking all your attendances. Maybe Friday I'll go and mark your attendances. Please make sure that you also look, you guys have books, look into the chapters that we have already completed. Go through those chapters. If there's any question, if there's anything that you think should be questioned, should be asked, feel free, we'll come and discuss it again. Okay. Other than that, I think for today, we did speak a lot about it, and we'll see each other tomorrow, 8:30. Okay.
Ma'am, do we have class on Saturday?
No. Hello? Yes. Yeah, I'm good, thanks. How are you? Good afternoon. Yes, please.
Hi.
Okay.
Hi.
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 Oh, yeah, sorry, it's my little one. So,
Hey.
my dear. I just got a phone call and got here. So, are we done for today, everybody? Is it okay? Is there any question?
Bye bye.
You don't have to say.
How are you saying bye?
See? So say bye-bye to everybody. Say bye-bye. See you tomorrow. Yeah. Take care, everyone, and look into everything. If there are any, let me know. We will discuss it in class. Okay.
Okay, ma'am.
Laptop.
Take care. Bye-bye, everyone.
Bye. Have a good day.
Like, how do you come across like people who vomit, and like you also have a like the urge sometimes, like the patient vomits and you don't feel well. So
If Yes, if things happen like that, you always there are situations when if someone vomits, you also get that thing. If it's
yeah,
not all the time, if it's sometimes it happens, you can always get an excuse. You can ask someone, yeah, or let the supervisor know. Oh, you know what? Today I'm not feeling well. My patient or my client in this bed throwed up. Is there someone who can help? I might do something else for them. I might change. I might do something like I will provide some other care, but because I'm not feeling well and I'm like having this, I'm
no,
having
how
the,
it's like how do you I like if some patient did vomit, but how can I stop myself, like, or with it comes with experience or it's come over the time.
it comes with over the time, and it is the situation teaches you. I'm telling you, the situation teaches you. If this is a client, let him vomit, give him a bag. Once he or she is done, you just then try to clean up. Even and your nurse also needs to help. It's like with time, things change. And when you see, sometimes when you're working, the way like the situation, the facility or the workplace where you work will give you a lot of experience. Not all the time you will come across people who vomit. Very rarely, just because you're working in a residential care. Like things happen, you will learn it. Let them vomit, give them a bag. Make sure they are on either they are not lying in the sitting like lying. They are sitting up so that they don't choke. It doesn't go into their airway. uh, give them a basin or give them a throw bag, let them complete a call bell in their hand so that once they are done, then you go in. and your nurse or your partner. You don't do things off your own. It's not a one-person job. Again, if she threw up, give them a wipe. Let them know, hey, my dear, can you please wipe your hands first? Can you put it in the garbage can here? So you need to redirect them. You don't do, okay, I will wash your hand and wipe it. No, this is a wipe. Wipe your hands properly. Can you put it in this garbage can? Yes. Now, can you turn on? Then we'll help you with reposition, with the gown change. But wiping your, can you please wipe your mouth? Yes. Now put it in here. So you promote independence. Instead, you doing things for someone all the time. Right?
Yes.
That is, oh, whoa. So these are some of the things that you have to know. Always, always make sure you have them by kind of telling them to do things, but not doing things. Politely, hey, you know what? Here are the wipes. One by one, give them instruction. Wipe your hands, put them here. Now wipe your face. Can you please wipe your neck around here? So they would do it. Okay. Any other
Yes.
questions?
Not as of now.
No problems. If you come across anything, let me know. We'll discuss it whenever time. Okay. Thank you. See you tomorrow, my dear. So, bye.
What's the plate number?
98.